I would like to welcome to the stage Professor Peter Nash to talk about the clinical value of upadacitinib or Rinvoq across rheumatology. Professor Peter is a professor in the School of Medicine at Griffith University, Queensland, and director of the Rheumatology Research Unit on the Sunshine Coast. He's a former member of the Therapeutics Committee of the Australia and New Zealand Bone and Mineral Society, and also he remains one of the International Steering Committee for GRABA. He is on the editorial board of Annals of the Rheumatic Diseases and R&D Open. He has published more than 210 peer-reviewed papers. Professor Peter, the floor is yours.
Very much. It's lovely to be my first overseas trip in 2 years. And I thank you very much for the very kind invitation to meet our friends Waleed, and we thank Nancy for all her assistance. And I hope I can make these slides change. Because if I press the button and nothing happens, it's supposed to advance one slide. There we go. So we've done all that. Don't blame AbbVie for anything that I say. It's all my fault. But the slides we've tried to put together in a nice case. So we've got a 29-year-old man. He's married, 2 young daughters, seropositive, bad arthritis. He can't do his normal occupation. In our country, we would start with methotrexate and the second conventional synthetic. In this case, it happened to be leflunomide, but it could have been whatever, cilazapyrin. We have to have 6 months of methotrexate plus a second drug before the government will reimburse a biologic. And I blame the EULAR guidelines for the amount of prednisone that we use. Once you give these patients the bottle, they self-medicate doses and it's very hard to get them off the last few milligrams. So lately we've been using a depot injection of prednisone, even repeated 2 or 3 weeks later, intramuscularly, rather than give them a script for prednisone tablets. Very hard to get people off in my experience. Anyway, he had plenty of swollen joints. He was still in trouble after 6 months. So the question is, what do we do with this man? And really it comes down to if you're going to use a JAK inhibitor, and in our country, it's about 30% of the market. It's about 30% of everybody who's failed methotrexate goes straight to a JAK, and everybody who is TNF-IR goes straight to a JAK. And you can see why, because there's been a number of studies that show they're superior to the gold standard, which is methotrexate plus adalimumab in many countries around the world, oral versus parenteral, and you need a cold chain. You need to keep these things refrigerated. Short half-life if you have to stop for infection, for pregnancy, for elective surgery. No immunogenicity if you stop and start is a big advantage. And again, we have a strong Asian focus in our country. And in Asia, where they have to pay for every single tablet, they often start methotrexate plus a JAK. As soon as the patient's in remission or low disease activity, they keep the methotrexate going and stop the JAK and then restart it if they flare. And that way the patient can afford the medication. Lots of cytokines are blocked, metabolism straightforward. It won't be long before tofacitinib is off patent, and then it won't be long before baricitinib, etc. The generic potential means the possibility of cheaper therapy for our patients down the road. You can buy baricitinib in Bangladesh for 90 cents a tablet. I don't know how much baricitinib is actually in the tablet, but that's another question. Monotherapy, this is a big area where the JAKs are very important. We're used to this safety profile of about 10 years and lots of indications, as you can see. Please understand that the cytokine inhibition is reversible and lasts a short period of the 24-hour dosing period. And that reversibility is what allows the inhibition not to cause severe immune deficiency. This particular agent has a half-life of about 9 to 14 hours, is excreted predominantly in urine feces and goes down the CYP3A4 pathway. The only important interactions, ketoconazole, metabolizes it fast. Ketoconazole blocks its metabolism, so you have to be careful with the dose. Rifampicin, if you're using it for latent TB, induces and chews up the agent quickly, and you might then need a higher dose. So they're the only two that are important. But interestingly now, that you've all seen the 9 phase 2/3 trials, over 8,500 patient years of experience, and Gerd Burmeister at ACR Convergence showed up to 9 years with a median of 4.6 years of follow-up with this particular drug and a very extensive clinical trial program, including MTX naive, a head-to-head against the gold standard, monotherapy, the safety of other conventional synthetic DMARDs with upadacitinib, and the post-TNF trial, and then a trial against abatacept, which was a select choice. And the bottom line is that they met every primary and secondary endpoint that they tested with a consistency of response across the entire program. Second time, RA Beam was the first time, but this is the second time ever in a head-to-head against the gold standard that they showed superiority, both signs and symptoms, particularly pain, but also quality of life and function. You can see the response. This is the upadacitinib. Give your patients at least 26 weeks. In our country, after 12, you have to make a decision whether this response is adequate to continue reimbursed drug or not. And you can see that the responses, particularly at the higher level, is still increasing. So give them at least 26 weeks if they're partially responding to get the best out of the drug. And understand that because these agents block IL-6 and will bring CRP down, always look at the CDAI, which does not have ESR or CRP in it, to show the superiority, that it's not just the mechanism of action which shows the statistical difference, but it's a real statistical difference. Out to a year, most patients do not lose efficacy over, and this is remission. So you're getting 30–40% of your patients in remission over 12 months. And most interesting, what drives the superiority over adalimumab is not swollen joints, but pain, physician global, and patient global. And that opens the door for pain studies with all the JAKs, which means a topical JAK for post-herpetic neuralgia, peripheral neuropathy pain, reflex sympathetic dystrophy pain. There's a whole series of possibilities because these JAKs, which we'll talk about tomorrow, have quite a striking benefit on pain. These are the non-radiographic progression. It's not just an expensive anti-inflammatory. It does inhibit X-ray progression, both joint space narrowing and erosion scores. But these patients are eroding very slowly, 1 unit out of 300 or 400 units. But at least you'll be able to sell a patient that you start on this drug. I'll have about half of you in remission over the next 12 months. And I can promise you that almost 90% will have no X-ray progression. And that's not bad for any treatment. Very cleverly, they did a switch for the non-responders. So they said patients who are not doing well on adalimumab could switch to UPA, and patients not doing well on UPA could switch to adalimumab. And they both gained response from the switch, and there was no safety penalty by switching without any washout. So if you have a patient on adalimumab that you want to switch, if you have a patient on UPA that you want to switch, you don't have to wash them out to make that switch without there being a safety issue. So our patient decided from a friend's experience to try adalimumab first. Is there any data about TNF inadequate responders? Well, here are the other mechanisms of action after a TNF, abatacept, tocilizumab, and Ritux. There's some choices. That is the kind of typical response you expect, switching mechanisms of action. And what response did they get in this study over 6 months? 60, 40, 20, a very strong result, stronger than we're used to seeing with the mechanism of action switch. The only other drug that's done that are the IL-6 inhibitors that are parenteral. So again, he switched to the Humira with methotrexate, and of course he did very nicely, as they often do. And unfortunately, he decided to get injection site reactions. We tried warming the injection, we tried using an antihistamine, but he needed to change as well. He was very keen to come off methotrexate, as many of our patients do. So this is the monotherapy study, and it's nice to see a very robust 60, 40, 20 kind of response in patients who do not use concomitant methotrexate with their JAK inhibitor. And this is the background patients who stayed on methotrexate entering the study, then got blinded methotrexate and had a 40-15-3 response, as you would expect. So post TNFIR, they do well. As monotherapy, they do very well. And head-to-head against the gold standard, they did well. And of course, I'm not going to show you a patient who doesn't do well. At 3 months, he's really very happy with his response, DAS and swollen joints and inflammatory markers. And he's off and running in for his country in the recent African tournament and doing well. So that's RA, which you've all seen many times before. You've seen the depth of their program. You've seen the different patients that you and I have to look after that can fit as monotherapy, as TNFIR, or as MTXIR. But what's also exciting is that these JAKs work for psoriatic arthritis, as well as ankylosing spondylitis. And in the few minutes we have left, we'll race through. This is a typical patient of mine. Again, you have to have a couple of conventional agents for at least 24 weeks before the government will reimburse any medication. And he's got plenty of rash and plenty of joints. The clever part of their program for psoriatic arthritis was to have an active comparator, not powered head-to-head, but an active comparator, which again, by many, is considered the gold standard, adalimumab plus methotrexate. And lo and behold, they were able to show, this is the upadacitinib 15 milligrams, this is the adalimumab, this is background methotrexate, and they're able to show in MTXIR patients that they were numerically different. You have to be careful these days what you call statistically superior and what you don't call statistically superior, but it was decided it was non-inferiority margin was met. And we're used to using TNFs, we know what to expect. And this agent using an active comparator was no less and numerically a little better than the gold standard. That's MTXIR, and these patients are TNFIR, and they can be very difficult patients who have failed a couple, 2 or 3 of the biologic agents. And rather than switching within class, TNF after TNF after TNF, changing mechanism of action, 60, 30, 15, a very nice response in a very difficult group of patients. And the benefit persisted out to a year. It didn't drop off over time, as many of the other agents want to do. And again, you can see for the better responses, the curve continues to grow up to 24 weeks before it tends to plateau off. So if you have a partial responder at 3 months, give them 3 months more, because you'll pick up another 10 or 15% of patients who have a nice ACR 50 response. And again, they showed that they would stop X-ray progression. Methotrexate can't stop X-ray progression. The conventional agents can't. Up till now, it's really only been the TNF inhibitors and the 17s, the 23s, and now you can see the JAK inhibitors can prevent X-ray progression in psoriatic arthritis. Their skin improvement was really very good for an oral medication. They were getting PASI 75s of about 60%. What do we expect with a TNF? About 40, 50%. What do we expect with methotrexate? 40% if we're lucky. What do we expect with apremilast? 40% if we're lucky. So what did we get with tofacitinib? 40%. So this is really quite a nice skin response. And most of my patients only have mild rash, but bad joints. The derms see terrible rash with not so bad joints. And we share the ones in the middle who have severe joints and severe rash. When we're doing trials, we struggle to get 3% body surface area to get them into the trials. So that kind of response works quite well. And even PASI 100 complete clearing in about 1 in 3 patients. So that's not bad for an oral medication, but they have to work for the other domains, enthesitis and dactylitis. And again, compared to the adalimumab, a very nice response out to a year, and dactylitis, which can be very difficult to treat, also very comparable. TNF, which we're used to using, and the JAK inhibitor met the non-inferiority margin for it. Now, you can also look at the spine as part of PSA 1 and 2, and the GRAPPA new recommendations will be coming out for the management of psoriatic arthritis this year, probably show some at EULAR, and the axial part I was involved with, and it looks like there's Angst-Bond type axial with a psoriasis rash, and a group that have asymmetrical axial PSA, which I think is quite a separate and different group. Lastly, before we run out of time completely, nice study in ankylosing spondylitis, showing the ASAS-40 around 50% over 3 or 4 months and persistent out to a year. So a very nice response in the axial domain. And this looks at more stringent criteria. And again, you can see ASAS in active disease and partial remission, very nice responses out to 40% at a year. And lastly, the patients are only interested in pain. And again, very marked improvement in back pain, nocturnal pain, and peripheral pain. So the JAK works for AS as well as psoriatic arthritis. Now, nothing is going to be an advance unless it's safe. And tomorrow in the JAK session, we'll have a long talk about oral surveillance and the whole JAK safety issue. Zoster, clearly a signal with all the JAKs, and we have to think about how we manage zoster, which they tell me is not a very big problem in the Middle East. But it's nice that there's a comparator of adalimumab methotrexate to compare all the numbers with. There wasn't a difference out to 4.5 years of exposure in the 6 phase 3 studies as far as TB, opportunist infection, serious infection, malignancy, et cetera, all the things that we now worry about with oral surveillance, which we'll discuss tomorrow. This is not a very good slide. This was serious infection, opportunist infection, MACE, malignancy, and VTE. There really wasn't a big difference to the TNF in this patient population, which is out to 8 or 9 years, 8,500 years of patient follow-up, nearly 4,000 patients altogether, but very happy to discuss that. I know we're running very short on time. So this particular medication, 4,500 patients, 8,500 patient years of exposure, no new signals bubbling to the surface. And they've almost done their own oral surveillance by continuing that adalimumab arm through many of their studies select compare out to 3 years and maybe even longer now. So there's some data of efficacy in AS, all the domains of psoriatic arthritis, not just joints, but skin, dactylitis, enthesitis, and of course, all the different patient types with rheumatoid arthritis. Would be very happy to take any questions, and I apologise for racing through that very quickly, but we did have a very short amount of time. So thank you very much.
Thank you very much, Dr. Nash. That was an excellent talk and very nice review and going through the sweeping evidence of upadacitinib and the 3 main indications in rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis. We'll open the door for questions, and we'll start with Dr. Walid.
Hey, Peter. We've been having issues with the TNF retention rates. And are we possibly going to face the same issue with the JAK inhibitors overall?
Well, I think the major issue that we see with TNF retention is immunogenicity over time. You certainly don't get that with the JAKs. And it's a big advantage to be able to stop and start without running into that problem. So we are seeing in our country retention with the JAKs after 12 months of about 58%, and retention after 2 years about 40%. So that's what's happening. I think it's comparable with the TNFs actually. I don't think it's very different, but there's a theoretical advantage that you don't run into immunogenicity. And I think the only question is, do we continue combination methotrexate or do we not continue methotrexate? And that's an issue in rheumatoid particularly, where the combo always does better than mono. Less of an issue in AS and PSA, but in our hands, we start combo for 12 weeks, get the person into a good state, and then slowly wean the methotrexate away because it's been the one that hasn't worked, which is why they're on the JAK in the first place, with the ability to add it back in later if they flare. So that's how we manage that issue.
Thank you very much. Jamal?
I want just to ask about psoriatic patients. Did you notice any improvement in the extra skin and extra articular manifestations?
An excellent question. I've not seen any data of it being, of the JAKs being effective for uveitis. I don't think they cause it. I think they'll be neutral, just like the 17s are neutral and the 23s are probably neutral. But I can't recall a study looking particularly at uveitis. In the PSA program, they had a few cases, but not an increased amount. And the JAKs work very nicely for inflammatory bowel disease. So they're actually, in our country, tofacitinib has been approved for the treatment of ulcerative colitis. And they're doing studies with Crohn's disease. So I think it'll cover skin quite well. It'll cover inflammatory bowel disease quite well. I think it'll be neutral on uveitis. And if you have a patient with uveitis, the TNFs are the better choice.
Next question. This is the last from our audience. Then we'll move to some virtual questions. So please go ahead with your question.
Thank you very much. Excellent lecture. For both rheumatoid and psoriatic, but let's say especially psoriatic arthritis, I have lots of patients who are in upadacitinib and they stopped the methotrexate because of the GI side effect and to multiple medications pharmacy. The questions now when we start after failure of DMARD methotrexate with the black box warning, is it gonna change our decision in giving the option of the patient with anti-TNF and upadacitinib? Despite that, what we know actually it's more effective with JAK and the other medication than anti-TNF in some psoriatic.
So that's the key question after the FDA made their non-evidence-based decision to slap the black box on all JAKs when they had an issue with one, for all indications, when they had an issue with one indication. So I think that was particularly unfair, and it's all under review moving forward. The EMA has just announced a big JAK review, and that will also be interesting to see. So I think that the issue we'll talk about in detail tomorrow is about what the oral surveillance study really does show us and what we then should do with our patients who are at risk. My concern in our place, 30% of patients don't take methotrexate for whatever reason. So there's quite a large monotherapy group we have to treat. And then the other patients, the combination always in nearly every study is superior to mono, but then the patients vote with their feet what they'll continue with. We did a study I'll show you tomorrow of 1,000 patients, and 1 in 3 had stopped their drug without telling their rheumatologist their methotrexate had stopped. So it's a very difficult issue to give you a simple answer. Let's discuss it tomorrow with the oral surveillance data in detail.
Thank you.
We're running short of time, so I've got a couple of virtual questions from our virtual delegates here. Mostly about combined diseases like RA with interstitial lung disease. What's your opinion about using JAK inhibitors and baricitinib if patient have ILD?
We've had the same issue with methotrexate and interstitial lung disease. And I'm one of those people who believe if you get better disease control, you have less of an active interstitial lung disease issue. Now, there's no doubt if you're taking patients with early inflammatory changes in their lung or end-stage fibrotic lung, that's 2 very different patient cohorts. And of course, they're more prone to infection if they have a lot of damage. So I treat exactly the same way JAKs as methotrexate, control disease inflammation, involve the respirologist as percentage of lung involvement, and we're aggressive treating interstitial lung disease with rituximab, cyclophosphamide, ninatinib, the whole series of other drugs. So it wouldn't stop me using a JAK. Disease activity control is the most important thing.
Okay, what's about the lupus or SLE plus rheumatoid? Do you think there's any role of JAK inhibitors in that case?
Well, Lilly have just closed, we had patients enrolled, they just closed the baricitinib program for SLE because they couldn't show any efficacy in the large group. Either it missed its primary endpoint and didn't reach any of its secondary endpoints either. So it suggests that the JAKs may not be a good target in SLE, and that's fair enough. IL-6 is not strong in SLE pathogenesis, whereas those monoclonals that block interferon look like they do have some benefit. Those agents that are anti-B cell agents have good efficacy. So I don't think the JAKs will have a role on the SLE side.
Well, there are 9 questions on the online platform. We cannot go through all of them due to the time, but I'll finish with a question from my side. I mean, in Australia, you have massive experience with JAK inhibitors, probably more than anyone in the world. You were among the first who started using them. I mean, now moving from the non-selective JAKs to more selective JAKs, did you see any different patterns, better sustainability, better persistence, better response in terms of your clinical experience, or you probably, for you, no clear difference?
I think it's a very valid question now because we all have very difficult patients who have failed a JAK. Do we switch within class? And we are finding patients who've failed everything, gone on to the first JAK, done well for a while, then failed, switch JAK, they still can get a response. So they are not the same, just like all the TNFs are not the same. They have their own individual fingerprint of efficacy. But as a class, it's hard to show a difference in efficacy. I think the differences will be in their safety profile, and that will lead to which JAK you choose for which patient.
Thank you very much. We'll conclude this symposium, and thanks for attending. Dr. Nash, thank you very much.
Next speaker is Professor Danish Khanna, who is going to take us and talk to us about a hot topic, which is the scleroderma stem cell present and future. So Danish is a professor of medicine and director of University of Michigan scleroderma program. He has very good experience with the scleroderma treatment and research. So the floor is yours, Danish.
Thank you. Good morning, good evening, everybody. Can you hear me okay? Is that a yes? Okay. So let's talk a little bit about, I talked to Rajai, Dr. Namas, on what would people like to hear. So I have a few cases that I'm going to present today. I have 25 minutes. I'm looking at the clock out here. So I have 25 minutes and I want to spend some time, talking about how to manage actual patients. So all these patients I'm going to show you are real patients. So let's get started. Before we start, I just wanted to highlight a few evidence-based medicine, including a recent review article that we published in ANR that talks about scleroderma-related ILD, how to incorporate the 2 FDA-approved therapies in clinical practice. So I apologize, I'm not in person because this could have been a really interactive case. But this is a 55-year-old woman who came for new consultation for Raynaud's phenomenon. There are a few things I want to highlight about Raynaud's. There must be 2 color changes. So what I tell patients is to take a photograph when they say that they have Raynaud's phenomenon, because a lot of patients state Raynaud's phenomenon as feeling of cold fingers, which is not Raynaud's. You have to have at least 2 color changes out of the 3. Her Raynaud's started in 2019, so she was 52 when it started. Painful with numbness of the tips of the finger, no digital ulcers. She has family history of systemic sclerosis. She's worried about scleroderma. So how will you approach this patient? So, here's a patient with biphasic Raynaud's phenomenon. Here are the triphasic with the pallor, the rubor, and the cyanosis that you see. I'm sure everybody does nail fold capillaroscopy, and I'm not advocating to start looking at, trying to classify, differentiating between normal, early, active, or late classification. But it is very helpful in clinical practice to differentiate the nice, well-defined capillaries versus microhemorrhages, giant capillaries, and other aspects. So the thing I wanted to highlight was this paper from Vido's group that was published by Dr. Francesco Delgado, the team, and Dr. Marco Mattucci. And this is very, very helpful when you see a patient with Raynaud's phenomenon. So there are a few learnings of Raynaud's phenomenon. Raynaud's phenomenon is never primary when it happens in adults. Anytime you see a new Raynaud's phenomenon happening at age 25 or 30 or later, it is never a primary Raynaud's phenomenon. So I think that should give you a clue if a patient 55-year-old is coming, that this is not primary Raynaud's. Now, what the patient is asking you is, what is the risk of developing scleroderma? So here's the data. And I want to go over 2 or 3 aspects that are important out here. The first one is that they looked at the presence of anti-nuclear antibodies, scleroderma antibodies, abnormal pattern on nail fold capillaroscopy. That's all you have to say, normal or abnormal or puffy fingers. If you had an anti-nuclear antibody by immunofluorescence that was positive, along with any of these, scleroderma antibody, pattern, or puffy fingers, the risk of systemic sclerosis over the next 5 years is approximately 70 to 80%. So positive ANA with one of those 3 things, the risk is about 80%. If you had the scleroderma antibody along with puffy fingers, the risk is 95%. In fact, in my mind, if somebody has ANA, scleroderma antibody, puffy fingers, and Raynaud's phenomenon, they have systemic sclerosis, but they do not meet the classification. But in my mind, that patient has systemic sclerosis, but I just wanted to highlight that. So in a patient who has a negative ANA, so a new patient comes to you, they have Raynaud's phenomenon, and they have a negative ANA, the risk of systemic sclerosis over the next 5 years is only 10%. So just looking at the anti-nuclear antibody by immunofluorescence, doing the scleroderma antibodies, centromere RNA polymerase, and SCL70, looking at the nail fold pattern and puffy fingers, about 70 to 80%, and a negative ANA, about 10%. And you can see the risk out here that has been highlighted out here. And I use this in my practice all the time. So I wanted to share this new data that was published earlier this year. So the second case I want to bring is a very young woman who came to me, and it's a new consultation. The patient developed progressive skin thickening. She's RNA polymerase antibody positive, RNA polymerase 3. She has tendon friction rubs. What would you do for this patient? So what you see here is marked skin thickening over her hands. There's quite a bit of inflammation out here that is happening on her forearm. So it's developing into early diffuse cutaneous systemic sclerosis. There are 2 points I want to make here. Number one, RNA polymerase 3, there's a high relationship with internal organ cancers, breast cancer, lung cancer, ovarian cancer. So I always make sure you do an age-appropriate screening or family history. So one of the patients I saw recently had a family history of ovarian cancer and came with RNA polymerase 3. So I made sure I did an ultrasound to make sure that the ovaries are fine. But here the question is, how do you treat this patient? So there are 3 phases that a patient with scleroderma goes through in diffuse cutaneous. Early puffy fingers, the first patient I showed you, puffy fingers. The patient yet doesn't have the systemic sclerosis. Fibrotic phase, the patient I showed you before this, and an atrophic phase. Now, part of the systemic sclerosis is relationship to internal organ involvement, but part of here I want to highlight is that we must be treating these patients. You shouldn't not treat these patients because it's associated with pain, stiffness, hand contractures, and the disability of the hands. So here are the traditional immunosuppressive therapies that Janet Hope, my mentors, Phil Clements, Dan First, and others have proposed, but majority of us tend to use mycophenolate mofetil. So we should be treating these patients. I tend to use mycophenolate mofetil. People have used methotrexate, and I tend to use IVIG once a month, similar to what you would use in inflammatory inflammation of muscles in these patients on a monthly basis. So who do you treat? If you see a patient with puffy hands, very early in the disease, but they are anti-scleroderma 70 or anti-topoisomerase positive, or RNA polymerase 3 positive, and or have tendon friction rubs, the risk of them developing diffuse cutaneous systemic sclerosis is 80% or higher. That's the patient I would treat and not wait for them to develop progressive skin thickening. If you see a patient like this, who I'm examining here, marked skin thickening, within the first 4 to 5 years, all of these should be treated with immunosuppressive therapies, irrespective whether they have ILD, whether they have GI involvement, whether they have cardiac involvement. You should be treating the skin involvement to improve function, to decrease the progressive skin thickening, and improve quality of life. On the contrary, this patient who has developed atrophic skin, and there's quite a bit of variability, I'm just giving you some guidance, so you have to examine the patient. But if their only treatment is if they continue to have progressive disease, which is rare after 4 to 5 years of onset of systemic sclerosis. Do not forget the role of occupational therapy and physical therapy. I cannot overemphasize. Here's a patient of mine before occupational therapy, and then they had weekly hand therapy with a therapist. And you saw this improvement, which is a very large improvement from a patient standpoint, juxtaposition of your thumb to the little finger. And then here's another patient that you see this improvement in the hand function. So treatment, the take-home message is treatment of these patients in the early phase with immunosuppressive therapy. Okay. So let's move to the next patient, where I want to spend some time on management of ILD now. So this is a physician who came to me, 52-year-old female with new onset Raynaud's phenomenon. Average age of onset of scleroderma is 50. So perfect age, perfect time. She already had the workup. She's SCL70 antibody positive. She has minimal reticulations on the lungs. Her primary care did it. Her CRP, and I don't know why they did it, but was elevated. The normal is less than 0.8 milligram per deciliter. She's active. She has no shortness of breath, and her FVC is 82% and a diffusion capacity of 80%. What would you do to this patient? She has no skin thickening right now. She has no puffy fingers. This is what the presentation is. And the question I'm asking the audience is, would you treat this patient without any skin thickening? So I want to go to the interpretation, because you do a clinical trial and then you have to interpret this patient's, how these patients will be in clinical trial. So we did this trial that I've presented many times, and I'm sure all of you are aware of, called FOCUS trial. And the FOCUS trial took patients with diffuse scleroderma. So our patient doesn't have diffuse scleroderma, but took patients with diffuse scleroderma and randomized them to tocilizumab once a week or to placebo once a week. And we enriched the patients for early disease, progressive skin thickening, and elevated acute phase reactants, ESR, CRP, or platelet count. And so here are the patients that we recruited. 210 patients all had diffuse scleroderma with skin score of 21, normal pulmonary function physiology. And what shocked us is that we did a HRCT on every patient, and 66%, or 6 out of 10 or 7 out of 10 patients had evidence of ILD. So the take-home message I want you to take here is that if you see an early diffuse scleroderma patient, and the predictive factor here are two: anti-scleroderma 70 antibody or elevated ESR, CRP, or a combination, 6 or 7 out of 10 people will have ILD. So this is a patient with early ILD. This is a patient of mine who has progressive ILD, and you can see the progression of the lungs, and you can see some bronchiectasis, and you can see the traction bronchiectasis that is happening on this view. So when you see early diffuse patients or anti-topo-1 antibody, do acute phase reactants, because 6 or 7 out of 10 people will have early ILD. You must be doing HRCTs. That is the only way to figure out whether they had ILD. If I take the same patient and I showed you this FVC, you would say, well, the patients don't have ILD, but then I'm showing you the data that 66% to 70% had ILD. So what we saw in the analysis was that patients who went on tocilizumab had this beautiful stabilization of lung function, and patients on placebo had this remarkable worsening of lung function over 1 year. In fact, they lost 250 ml. So we are all rheumatologists. What does 250 ml means over a year? So all of us, if you are over the age of 25, lose 25 to 30 ml of lung function every year. So if I don't do percent predicted in you, if you are a male, about 4 liters, you are losing about 25 to 30 ml every year. These patients lost 10 times that what you and I should be losing, a big precipitous drop in their lung function. And the question is, why did they drop? And I showed you, because majority of these patients were anti-topoisomerase positive and an acute phase reactants. So I showed you this data. Now, we have to interpret this data for our clinical patient, because that patient met all the other inclusion criteria, except she doesn't have diffuse cutaneous systemic sclerosis yet. She just started with the disease, somebody did a HRCT and everything. So how do you interpret the data? So I'm going to show you some of the data that will be presented also at the World Scleroderma Foundation meeting that's virtual, that is starting next week, where we did quantification with the computer on all the lungs. And this data will be presented by Dr. David Ruffey. And we looked at something called KILT. And it doesn't matter, but it's a quantification of ground glass opacity, honeycombing, and reticular changes. And you see this patient that has quite a bit of inflammatory fibrotic changes in their lungs. And what we showed in this trial, in the trial tocilizumab, that despite having early disease, despite these patients coming without a knowledge of ILD, majority of them, about majority, if you see here, a large proportion of patients, 77%, these are number of patients, 77% of these patients had moderate to severe ILD already early on. And despite that, they had normal lung function. So I want you to remember that. You should be doing HRCT. That is the take-home message here in every patient with early systemic sclerosis. You cannot trust a forced vital capacity to make your decision when to treat, how to treat, and whether they have ILD or not. And what we showed out here is that if you look at the tocilizumab arm, and this is the tocilizumab arm, and you see the stabilization, and this is a placebo arm that you see keep on declining. But that decline happened in the dotted line, even if you had mild, moderate, severe ILD. Whereas tocilizumab was effective in the solid lines out here, whether you had mild, moderate, and severe ILD. So in this patient, I would start tocilizumab because she has 2 out of 3 risk factors. She's anti-scleroderma 70 antibody, which is a risk of progressive ILD. And number 2, she also has elevated acute phase reactant. And this patient I would treat aggressively because I do not want this patient to lose 250 ml over the next 1 year. You all know scleroderma ILD is a fibrotic disease. It's an irreversible disease. You cannot reverse somebody if they have lost 250 ml of their lung volume. So you and I will lose 250 ml over 10 years. If you lose 25 ml every year, this patient lost 250 ml over 1 year. So the role of tocilizumab in scleroderma ILD is early ILD. I'm not saying mild, early ILD with elevated acute phase reactants with systemic sclerosis, early ILD with progressive skin disease, early ILD with anti-scleroderma 70 or SCL70 or anti-topoisomerase 1 antibody, active skin and musculoskeletal disease if you start mycophenolate, and some people are starting to use, including us, in combination with mycophenolate. So now, this is a 4th patient of mine. She's a 52-year-old patient, 3 years of systemic sclerosis, has diffuse cutaneous scleroderma with skin score of 30. She has HRCT, she had NSIP pattern. How would you treat this patient? So most of us would say we will start this patient on mycophenolate. This patient came about 3 to 4 years ago, and that's what I did. So I started the patient at 500 milligrams twice a day, and over the next 2 months, I increased it to 3 grams per day. So remember the dose that I'm proposing, not 2 grams, 3 grams per day. 70% of the patients are able to tolerate it. She had improvement in her skin score, in her symptoms. Her skin score improved from 30. And Dr. Namas can tell you, we do skin score at every visit at Michigan. So she went from 30 to a skin score of 4. So this is a patient we talked about treatment of early diffuse scleroderma. She feels fine. She does a PFT every in shortness of breath. And then this is a lung function. And let me show you something. So this is a real patient, and you can see the lung functions that have been started to be done since 2018. And one here just for everybody, because this is an American way. So this is January of 2018. And you can see I do lung function every 4 to 6 months. You can see that. So it is happening out here. And you can see the trend in decline. So there was stabilization of lung function over a period of 1.5 years. And then she starts to have this decline. So what I'm trying to educate the audience out here is that you can't just look at the last 2 or 3 findings of lung function. You have to look at the trend over time. And there's a clear trend in decline in forced vital capacity in person predicted. Forced vital capacity in person predicted should be same if you do not have any COPD, ILD, and things like that, because it adjusts for your age. So person predicted should be same throughout your life, because they're adjusting for your age, your height, your gender, and things like that. So you see the FVC in ml declining, and you see somebody has lost almost 13% of their lung function over a period of 3 years. And that is a real decline. Despite her saying, I'm not feeling short of breath, that is a real decline. And then you also see the diffusion capacity is also showing a trend, but you see the variability in the diffusion capacity that is happening here. The other learning point out here is you can look at the FEV1 to FVC ratio, and that is 87%. So we know that she doesn't have obstructive lung disease, and that has been consistent throughout. So this brings me the role of use of nintedanib, and I'm giving you real cases because these are real patients, how I treat these patients rather than giving you just an academic presentation out here. So this is what we saw in the census trial. The patients had, half the patients had diffuse scleroderma, FVC in ml was about 72%, and they had quite a bit of fibrosis. And what you saw in placebo was double the decline than what you saw in nintedanib. However, a very different patient population, 93 ml compared to 250 some ml in the tocilizumab arm. So this is how I have interpreted this data. So these patients came on mycophenolate 50%, and they were put on nintedanib. And what you see is a synergistic effect of nintedanib and mycophenolate versus if you were not taking mycophenolate and just on nintedanib. So this is my interpretation of the data to my patient. 3 years of disease, progressive ILD on mycophenolate, doing otherwise fine. The skin is improving. She feels fine. So I added nintedanib to this patient population. So role of nintedanib, progressive ILD on mycophenolate or other immunosuppressive therapies, predominant ILD. In other words, they're predominant ILD. They don't have skin, joint, other issues going on. There's a data showing that maybe UIP pattern on HRCT, not just scleroderma ILD, but any CTD ILDs would be effective. Recurrent infections on immunomodulatory therapies and patients who have very aggressive scleroderma ILD. So I want to go to the treatment of stem cell transplantation. I'm not even sure whether in UAE stem cell transplantation is offered, but I'm happy to take questions for that. There's a lot of data that if you have really bad autoimmune disease, you can reset the immune system. And there are different ways to reset the immune system that I will not talk today because of the limited time. But here's a trial called SCOT trial where we gave people stem cell transplantation, autologous hematopoietic. We are giving your stem cells back into you. We gave people a lot of radiation to the body to kill all the cells, dividing and non-dividing cells, and gave IV cytoxin, treated your stem cells with CD34 column, and gave it back to you, versus monthly pulse cyclophosphamide for 12 months. So who are the patients? So think about the patients in your practice. They're early diffuse scleroderma patients with ILD. Why early diffuse? Why ILD? Because you want active disease. You want a disease that will reverse. If I'm going to put somebody on stem cell, want reversible disease and want disease with predictably poor prognosis, and pulmonary disease and prior renal crisis have a 50% mortality at 10 years. So here are the patients. We'll just focus on this group. Very young people, average age of 44. So not your typical 60, 70-year-old people. Disease duration of 2 years, 100% lung involvement, and FVC of 75%. So the patient that I showed you, the one previous on nintedanib, if her skin was also worsening with MMF, I would have offered her stem cell transplantation and non-nintedanib. Similar FVC, similar disease duration. She was 3 years, this is 2 years average. But the difference here is that the skin is getting worse, the lungs are getting worse out here, and this is a perfect patient for stem cell transplantation. And here's the data on event-free survival, and there's the data on overall survival on stem cell versus people who got cytoxin or chemotherapy. And I think one thing that has educated me, taught me quite a bit is that people on cytoxin keep on getting worse. Almost 44% required other immunosuppressive therapy, 15% develop pulmonary hypertension, 12% developed heart failure, where majority of the patients with SCOT protocol did very well with very little relapse of the disease. So here are the two patients, representative patients. I introduced the kill to you, baseline, 24 months, end of the study. And you see the progressive non-specific interstitial pneumonitis happening in this patient. On the other hand, here's a patient with stem cell transplantation And stem cell transplantation is the only treatment that you can give that can lead to improvement resolution of ILD. And you can see this patient, the lung fibrosis and total lung involvement is going from 48%, 42% to 14%. Again, these are representative pictures, but you get the point that if you have a patient who's not responding to CellCept, who's not responding to tocilizumab, rather than keep on putting therapies after therapies after therapies, it's best to send this patient for stem cell transplantation. And then I have one case, and I think I will be done on time here, on pulmonary hypertension. So there's a new therapy approved for group 3 pulmonary hypertension. So we all know pulmonary hypertension is a hemodynamic observation, and pulmonary hypertension is divided into pulmonary arterial hypertension. I've talked to you colleagues many times on behalf of Janssen, the importance of DETECT algorithm differentiating PAH versus PH due to left heart disease, which is the most common cause, versus PH due to lung disease. The question I want to ask my colleagues is, how do you differentiate these two? Because if you look at the right heart cath, the findings are the same. So here's my patient, 70-year-old patient, very long-standing scleroderma, comes every year, severe scleroderma ILD, there's no doubt, right? I mean, you see here, there's quite a bit of ILD, especially on the left side of the about 30% of the 40% of the lung is involved. She's complaining of increasing shortness of breath with exertion. She has positive for DETECT algorithm, and she has a right heart cath. Now, right heart cath shows increased pulmonary pressure, increased pulmonary vascular resistance, and a normal wedge. So what does this patient have? Does the patient has pulmonary arterial hypertension, or does the patient has pulmonary hypertension due to ILD, group 1 versus group 3? So group 1 pulmonary hypertension is pre-capillary pulmonary hypertension, and this is a new definition. And group 3 pulmonary hypertension is pre-capillary pulmonary hypertension with significant amount of ILD. And the reason to differentiate the two is the difference is one is caused maybe by autoimmunity, prevascular, pre-capillary, and this is caused by pre-capillary damage due to hypoxemia. And the importance of the difference is the ventilation perfusion mismatch. If you give this patient potent vasodilator, they will have ventilation perfusion mismatch and shunting of the blood that will cause desaturation and hypoxemia and increasing shortness of breath. So this is my last slide. So this was a paper that was published last year in New England Journal of Medicine, where they gave inhaled treprostinil, which is a prostacyclin analog in pulmonary hypertension due to interstitial lung disease. So my patient I'm showing you, this would be exactly the patient where you would consider giving somebody inhaled prostacyclin analog so you do not have a systemic exposure and you do not have the VQ mismatch. And this patient, although meets all the criteria for pulmonary hypertension, this is PH-ILD rather than pulmonary arterial hypertension. And when you look at the data, the hall walk distance, 6-minute hall walk at week 16, you see a very large clinically meaningful difference in the patients who were treated with inhaled treprostinil versus placebo. So I just wanted to bring you, this is a new development in the management of PH-ILD. This is a first drug that has ever been approved for pulmonary hypertension due to ILD. And with that, I will stop and thank you very much. And I hope I didn't go over the time here.
Thanks, Dinesh. We'll just have time for 2 or 3 questions from the floor.
Hi, Dinesh. Nice to see you. You've lost a lot of hair.
Oh, I cut my hair yesterday.
So regarding the autologous transplant, cost-wise, how much for the transplant is it for patients who are progressing?
How much for the transplant? What is the cost of the transplant, you mean?
Yes.
So it depends. The transplant can cost between $150,000 to $200,000 in US. So that would be the cost of the transplant between $150,000 and $200,000 in US. So that's what the transplant cost here. Is the transplant covered in US? I mean, in UAE?
Sorry?
Is the transplant covered in UAE?
Oh, no,
you do
no,
there?
no, we do not have any cover.
Okay. So yeah, that's what I would suggest for the transplant. I mean, the data is as good as it gets with the transplant. So yeah. So I showed you the data with the transplant. Yeah. So the transplant, we tend to do very aggressively transplant in the patients who have a progressive disease.
Right, okay. Yeah.
Hey, thank you very much for your comprehensive lecture. And I think a GIT problem in scleroderma is the more difficult part to be treated. I have one of my patients with GAVE, gastrointestinal vascular ectasia, and I don't know what to do with him. Can you advise me? Thank you.
So gastric enteral vascular ectasia, it's an earlier complication and it's an endoscopic finding. The classical presentation would be somebody in early diffuse scleroderma patient who comes to you and has iron deficiency anemia, and they usually have a hemoglobin in 8s or 10s, and you do a scope on them, and in the gastric part of antrum and enteral part of the stomach, you see these dilated blood vessels. The treatment out there is simple, yet not simple. You work with a gastroenterologist who does argon laser coagulation. I'm not sure whether your patient had the argon laser coagulation. Maybe you can tell me about it.
He receives
Sometimes
the argon. He receives the argon each time, but he bleeds again. Yani, the ectasia come again. But in our point of view as rheumatologists, is there any new immunosuppressive or biology that we need to decrease this side effect of scleroderma?
Does the patient has diffuse scleroderma? What kind of scleroderma does the patient have?
He has diffuse scleroderma, but mainly the GI problem.
And how's the skin? How bad is the skin? Fibrosis.
I don't know the skin scoring now. I didn't remember, but he has moderate skin stiffness.
Okay. So people with GAVE are unable to absorb oral therapies, so like mycophenolate, mofetil, and others. So if you're going to give this patient some treatment, my suggestion would be, say it again.
Cyclophosphamide.
Well, so people have cyclophosphamide, people have used IVIG with the improvement that, and all these are case series, but anything that you'd want to give IV cytoxin, many people have published the beneficial impact of cyclophosphamide on GAVE, IVIG. We have used tocilizumab, but whatever you give, you should be giving as a sub-Q or an IV therapy in these patients.
Yeah, thank you.
Absolutely.
Thank you so much for a great talk. There's been a lot of discussion in the community about post-COVID chilblains and Raynaud's. Either it's an epiphenomenon or whether it's truly pathological as an interferonopathy. What are your thoughts on both the chilblains and Raynaud's? Should we be taking it seriously, or is it just something that will go?
Oh, wow, that's a that's a difficult question to answer without knowing the whole epidemiology. We have seen the same thing out here. We get consultation for that. I think at here the chilblains with the vasculopathy that you talked about, we tend to use quite a bit of PD5 inhibitors and low-dose aspirin and antiplatelet therapies. Jason Knight within our system, he's a guru of vasculopathy and antiphospholipid syndrome associated with COVID. So we're starting to do quite a bit of studies to look at the different cytokines and chemokines that are upregulated in this disease. So I don't have any thoughts about it other than saying we're seeing the same thing and we're treating them with the PD5 inhibitors and low-dose antiplatelet therapies.
Sorry, we are running out of time, but just one last question from my side, actually. When we compare actually the cyclophosphamide group to the transplant group, are we actually comparing the doses of cyclophosphamide? Because, the most active component is the cyclophosphamide, isn't it? Controlling the disease. So is it just a comparison between two doses, massive dose of cyclophosphamide versus monthly cyclophosphamide?
So the doses are different. So it's, I don't know whether you can see my slide. I can't use my pointer anymore, but if you see the dose, the total dose that was used in the stem cell transplantation arm is actually 9 grams. Whereas if you use a cyclophosphamide arm, the total dose is 16 grams. So it's almost double the dose that you use in the Cytoxin arm. The difference between the two is that you are taking out your stem cells and treating it with the CD34. CD34 column takes away the pathogenic cells that may be causing the autoimmunity. Number two, you're giving them total body radiation, 800 CGY, which is a very large radiation that is you're giving, and you're killing all the actively dividing and non-dividing cells that may be pathogenic in the disease. And of course, then you're giving them ATG. So it's really what we call myeloablative transplant with the total body radiation. But the dose of Cytoxin is half what you would give if you were giving it on a monthly basis over 12 months.
Right, thank you very much. So we'll invite back Professor Peter Nash to talk to us about psoriatic arthritis. Where can we go wrong?
Thank you, Mr. Chairman, and I thank Waleed for giving me this topic. Where can we go wrong with our management of psoriatic arthritis? So if we could have that slide, please. I hope it all works over there. Yes. Where can we go wrong? So we've been doing trials with all modern targeted and biologic agents in psoriatic arthritis for a long time. So I thought if we can define the 10 commandments of the management of psoriatic arthritis, then maybe we can avoid going wrong altogether. So what would be the first commandment? In our place, the general practitioners don't make the link between skin psoriasis and psoriatic arthritis. They send patients off to have forefoot surgery. They get told they've got Morton's neuroma and they get it cut out. And then finally someone decides it's bursiarthritis. We have general practitioners sending patients away with one swollen knee, off to the orthopedic surgeon to have arthroscopy, query septic when clearly it wasn't septic. So the penny has to drop and the GP has to make the link between the skin and the joint disease. And similarly, the dermatologist has to realize that sitting in their clinic is between 10 and 20% of patients who actually have PSA, and that some of these questionnaires that they're starting to use, a lot of hesitancy to use the questionnaires. I don't know why. They can be left out in the waiting room. They can be done before the patient even walks in to see them. If the score is elevated, they just know that something else has to be done. And these questionnaires have actually been validated and very high sensitivity and specificity. That's in the derm clinic. That's in the general practice clinic, 90 and 100%. So we have to somehow get these patients diagnosed. This is a study where Laura Coates simply tried the questionnaires in general practice. And again, it was very helpful with sensitivity and specificity of making the link between the skin and the joints and letting the penny drop. And no matter where you look, you always find about 20% undiagnosed inflammatory disease sitting in the clinics of the derm or the general practitioner. When we did our study, it was about 11%. So the question is, why would you bother? You bother because there is a window of opportunity, even down to 6 months in this Irish study, that you were 4 times more likely to have erosive damage and twice as likely to have functional disability if you didn't diagnose and treat those people over a long period of time. And what's happening in the field is they're really seriously thinking about preventing psoriatic arthritis. So I'm sorry you can't see the screen very well, but they're defining now a preclinical PSA. The triggers like environmental, trauma, genetics, all these things are important, But these patients have immunological abnormalities, but no symptoms and no signs. And then they define a subclinical group where with the sensitive imaging, you can see abnormalities in the joint, but still no symptoms. And then there's this vague prodromal phase where all they have is fatigue and aches and pains, but normal ESR, normal CRP, no synovitis, a preclinical prodromal phase, and then they present with swollen joints and it becomes obvious. And people are now treating at this stage with aggressive therapies to see if you can prevent this progression. And here's a retrospective study from Argentina. There's a whole series of them where they've looked in derm clinics with patients only with psoriasis, treat them with a biologic and prevent them developing psoriatic arthritis over time. So an interesting approach is to have a look in your own clinics. If the psoriasis is treated with a biologic, do they get less psoriatic arthritis over time? Because really our derms don't care. They're cosmetic derms, they're not physician trained, they don't think they've got the skills. And the only way it works in our country is you have a centre of excellence for the derms to send patients to, where they have biologics nurses, they can screen, they can monitor, they can do the paperwork, and that works very well. Most derms have a few patients on biologics. Some derms have a lot of patients on biologics. And we can tell the derms, oh, something hasn't happened over there on the screen. There we go. You can tell the derms, if you can see nail involvement, you're 60 times more likely to develop psoriatic arthritis. If you can show them what a dactylitis is, they're 20 times more likely. And it's very clear what are the predictors of having psoriatic arthritis if you have psoriasis. So very simple instructions, questionnaires, the derms can come on board with diagnosing PSA and sending them along early. Where else can we go wrong? Well, if we don't examine our patient and miss the psoriasis in the scalp or the small plaque, because it doesn't have to be extensive and they can still have psoriatic arthritis. This was a Dutch study where they took patients who definitely had PSA, gave 23 rheumatologists, no information, and 7 or 8 out of 23 missed the diagnosis altogether. So we've got to examine our patients and look in places where they don't like us to look and to help us with our diagnosis, particularly in the seronegative patient. So that's another place where we can go wrong. Now, treat to target has become jargon that we all say we do when most of us don't. The question is, the field can't even decide what the target is. I'm very impressed that our former speaker uses MDA as a target, and most of the field can't even agree on what the disease activity measure should be. And again, I'm very impressed that they use DAPS, so that's fantastic. Please don't use the DAS28 because it leaves 30% of the joints out. And please don't use the PSARC, which can't even distinguish placebo from active drug. So this poor girl who had terrible psoriatic arthritis, you can see dactylitis, nails, swan necking, deformity. Imagine living with this rash as a young 28-year-old mother of 2. But we need consensus in the field. What is the target and what should the disease activity measure be? And we have this argument across the planet of the DAPS devotees and the MDA, VLDA devotees. PAS-DAS is complicated and is for clinical trials only. You need a calculator like the DAS28. You can get it online, but you can see it includes enthesitis and dactylitis and a CRP and function and swollen joints, whatever. So quite comprehensive, beautiful for a trial. DAPSA does not have anything other than pain and joints and a CRP. So it tells you nothing about skin, nothing about nails, nothing about enthesitis, nothing about dactylitis. It's great for rheumatologists who only want to know about joints. MDA at least includes skin. includes enthesitis and HAC as well. But the point about a target is that you don't have to spend time doing every single one of these things. You're either at the target or you're not at the target. So if they're sitting there with 7 swollen joints, you know they're not in MDA, you know you don't have to do the rest, you have to make a decision whether you escalate therapy or you don't escalate therapy. So that's another place we can go wrong. I propose that this 3-VAS or 4-VAS, which is a simple visual analog score that you can have them do in the waiting room, gives you an objective number of disease activity that you can follow and over time. Very simple. Here's the 3-VAS, 3 questions, and you can measure it 0 to 10, and you can follow it along. And it's like the rapid 3 that people use in the PSAID in Europe. And I think that's practical for the busy clinic in the waiting room. And then you can have an objective evidence of what you're treating. Now, people treat to target, and this is from the Tacopa study. You have to understand that if you treat to target, you are 5 times more likely to have your patient on a biologic. And when that was done, they were all TNF inhibitors. And if you're 5 times more likely to have your patient on a biologic, your patients are 3 times more likely to have a serious adverse event. So the more you drive treat to target, the more you pay the consequences of serious adverse events using the old-fashioned TNF inhibitors with all the side effects you and I know and love over 20 years of experience. I think the newer agents are actually safer. What might be the 4th commandment not to get wrong? Don't call your patients easily fibromyalgia just because they've got aches and pains, no swelling, and a normal CRP, because they've got enthesitis everywhere if you actually image them and looked. Musculoskeletal pain in psoriasis is due to ultrasound confirmed inflammation in many patients. So just give that a bit of thought. They're complaining of symptoms, you can't find anything. Rather than writing them off as fibromyalgia, just examine a few of the enthesial points and see if they really have. This is the old hypothesis: skin first, enthesitis second, synovitis last, and then damage, and maybe we can do something at an earlier stage. So don't always write them off. The 5th commandment where we go wrong might be you've got to manage the comorbidities. And this is what makes us physicians, not just rheumatoid arthrologists. Smoking, cardiovascular risk will kill these patients. You might fix their rash and their joints, but the comorbidities will be what kills them. Do something about weight. In our country, it's alcohol excess. Actually measure blood pressures, follow their lipids and their fatty liver. Think about drugs and depression. You can actually see the inflammation in all their vessels and in their liver if you do sensitive imaging. These patients have a psoriatic multisystem disease. Please check comorbidities. The other place we go wrong is ignoring their skin and their nails because we're joint doctors. When GRAPPA had its first meeting to define a course set, left skin and nails out completely and had to be rethought about, and MDA includes skin now, because if you look at the impact on their mental health, and that's the mental health score of someone with cancer, these patients with psoriasis, bad nails, think they've got a worse disease than having cancer, and we ignore it completely, don't even ask them about their skin or their nails, and just treat their joints. The other commandment where we go wrong is in the axial PSA. Please be careful with the reports of MRIs because they wind up on biologic agents. And the more we look, the more false positive MRIs we see, particularly postpartum, particularly in athletes. And so all we're saying is you need to be a clinician and you need to decide if the story of inflammatory back pain and the examination of tenderness fits with what that MRI is showing you, so you don't overdiagnose. Now, the eighth commandment is a little bit controversial because I believe there's safety differences between the drugs we now have to choose from. We've used TNFs for 20 years and they've revolutionized rheumatology. The 17s, apart from a bit of a rare ILD, 1 in 1,000 per year, a bit of candida, we don't see serious infections. The JAKs we're going to talk about tomorrow, the 1223s and the 23s, it's hard to know what to put in their luggage bin. The newer agents which target one specific cytokine, I think have a better safety feel. The question was before from one of our colleagues, should we use them before a TNF? And we routinely use them before a TNF, unless there's a TNF indication like uveitis or IBD, because they're effective. They're no more or less effective in the head-to-head studies like SPIRIT head-to-head or the EXCEED study, but I believe they're safer. That's what we do. We're used to all of those things with TNFs. We accept the risk on behalf of our patients and we just treat them. In this part of the world, I'm sure TB is a major issue. There is no TB signal with the 17s, and I don't believe there is with the 23s. And we can now, for the first time, match the domains that the patient has sitting in front of us with the appropriate treatment choice to try and pick the medication that you can individualize for your patient. And further, we're now trying to define which biologic for which agent. This was the Tanaka study that's now being repeated around the world using flow cytometry, where the claim is that with flow cytometry, you can define a phenotype that should respond best to 17, a phenotype to 23s, a phenotype to TNFs, and the phenotypes that are a little mixed. And the patient who got given the appropriate biologic for their phenotype did better than just randomly picking a biologic as we do today. That was a small study, 60-odd patients, easy to show a difference. It's now being repeated all around the world to see if it can be confirmed. But wouldn't it be nice before the patient, before you have to make your choice of which biologic, you do a quick flow cytometry in the lab and it tells you don't waste time for 6 months with a 23 inhibitor when this person is unlikely to respond, give them a TNF instead. So that's the dream, like you do with breast cancer, you do the HER, you do the estrogen receptors, you do all this, and then you give them the appropriate chemotherapy. Small step, I hope it works out, we'll need to see. Number 10, you could say tapering. Here's a study where people stopped suddenly and that didn't work. Don't stop. 75% had flared within 6 months. Don't stop suddenly, but there's the guidelines from the EULAR guidelines on how to taper and which patients to successfully taper in, because all patients, whether it's for good or bad, want to reduce the amount of therapy they take where it's feasible. And there's some guidelines on how not to go wrong with tapering. The 10th commandment, I couldn't really think of one, so I think when you're doing research, think a little bit out of the box. And there's lots of interesting things coming. Maybe we should be thinking combinations now that we have some biologics that are very safe. This was a study of bimekizumab 17 inhibition plus a TNF. There wasn't a safety penalty, but unfortunately, they picked the wrong target. They picked rheumatoid arthritis, and it didn't really work very well. It made no difference to certolizumab by itself. Janssen are now doing guselkumab, 23 inhibition, plus a TNF, and we're recruiting for that study. Many places combine JAKs, methotrexate, or apremilast and TNF. I think it's Pfizer's developing a JAK1 TYK2 combination. And we're doing a trial with an adalimumab plus a steroid receptor agonist as a combination. So think a little bit out of the ordinary. We might get better outcomes if we induce remission and then back off to have a maintenance regimen. We'll have to wait and see what evolves. But if we believe the gut is important, then maybe we should be thinking about probiotics. We're just starting a trial in RA with a probiotic bacterial soup that looks very promising in psoriasis as well. So if you think this is important, then maybe we should think about probiotics and changing the microbiome. This was a nice approach where they showed it didn't work, to give them fecal microbiota as a transplant. Again, small numbers, short period of time, proof of principle. That one was unsuccessful, but I think if we believe the microbiome is important, then we better test that hypothesis. We'll be seeing more and more of these patients who are given immune checkpoint inhibitors for their malignancy, and they can develop classical psoriatic arthritis, as well as all the other things, pneumonitis, colitis, hepatitis, etc. So just be aware, and then you have to think about what of our agents is safe to give someone with disseminated malignancy to try and treat the psoriatic arthritis that the immune checkpoint inhibitor, which they can't stop, causes. Bottom line, prednisone's fine, methotrexate's fine, the TNFs are fine, tocilizumab is fine. The others really haven't been tested. So we do have a number of treatments that would be effective for psoriatic arthritis without having to stop the immune checkpoint inhibitor where you can. And just lastly, I've had a case of psoriatic arthritis triggered by SARS-CoV-2, but a bigger problem for us is the vaccine-induced flare of underlying rheumatism. So I think I've now seen everything within a few days of vaccine, from rheumatoid, PSA, giant cell arteritis, vasculitis, lupus, all of them triggered, causally related, previously well, vaccine, unwell from the day of the vaccine, developed the acute problem. I can never convince them that it was coincidental. So to answer Waleed's question, where not to go wrong, we need to do something about the derms and the GPs making a link. We better not miss a bit of hidden rash in the scalp. Treating to target's fine if we can agree what the target is and what the disease activity measure should be. Don't overdiagnose fibromyalgia. Do something about comorbidities. Don't ignore skin and nails. Interpret the axial MRI carefully. Think about what's the safest option if efficacy is very hard to separate in your choice of the treatment algorithm for PSA. Taper when you can, don't cease, and we need a research agenda to move the field forward. So with that, I will say thank you very much and happy to take questions.
Thank you very much. So the floor is open for any questions.
Okay, thank you, Peter, for a nice talk. My question regarding the axial psoriatic arthritis. Did you believe that the SS definition of axial spondyloarthritis and lesions in sacroiliac joints valid for defining psoriatic arthritis axial domain, or a little bit there is some changes between them?
Well, I think axial PSA is very tricky because I believe that they're two separate groups. The ASAS people sit in a clinic where they see ankylosing spondylitis, and people come in with inflammatory back pain. And they have symmetrical sacroiliitis, they have rising syndesmophytes, they have typical AS, and 9% of them will have psoriasis. So they think axial psoriasis is really AS with a rash. Just like they think uveitis is AS with the eye inflammation and IBD arthritis is AS with an inflamed gut. We sit in a peripheral arthritis clinic where we see psoriatic arthritis, Pawsey arthritis, dactylitis, and about a third of those patients will have axial involvement, but it'll be asymmetrical. It won't be as painful as AS is. It has much more cervical involvement. Any syndesmophytes is very asymmetrical. If they have sacroiliac joint involvement, it's one side, not two. So I do believe that there's this two groups, if you like, in axial PSA. And I think that the GRAPPA guidelines are trying to come to terms with that dichotomy and how we should manage it the best and how we should treat it. It's the same argument with axSpA with peripheral arthritis. Is it really psoriatic arthritis or is it not psoriatic arthritis? So it depends whether you're a lumper or a splitter. I'm a splitter because you'll never get an advance in treatment and cures if you lump everything together. So I think most of those studies that you're talking about were in typical radiographic axSpA where they have these different levels. I think that second axial PSA group will be very different in their MRI imaging than the classical AS with a rash. So it's a complicated answer to a difficult question.
Okay.
Peter, I have one question. So when we are talking about treat to target, do you think that we should include the comorbidities, controlling blood pressure, controlling, reducing weight? These things should be included in addition to that, taking consideration that now it is what we call psoriatic disease rather than arthritis or skin.
I think that's a very important point, and that's what GRAPPA tried to do. They have, ULAV's tried to make a treatment algorithm, usually based on very little evidence. No one's done the head-to-head this way and what you should switch to in any clinical trials, really. GRAPPA said, let's pick a domain and simply show what therapies work for each domain, and you decide what's appropriate for your individual patient. And then they made a big deal about comorbidities, had a whole page of what to do with comorbidities. So the answer to your question is we must not ignore them. I'm not sure you can incorporate them into an overall body index, because every time we've done that in lupus, in scleroderma, any treatment you test that's a new treatment fails because of the comprehensive nature. I think we should have a domain approach to treatment, not a total overall disease activity assessment.
Thank you. Okay. Yeah. Last question.
Hi. You just have mentioned that you would use IL-17 inhibitor as before starting anti-TNF. For those patients who fail IL-17 inhibitor, would you consider starting interleukin-23 rather than anti-TNF after failing IL-17 inhibitor? And where you will put JAK inhibitors in the treatment algorithm?
So that's a very good question, and that is how you individualize your treatment. As we heard before, if my 17 is failing, do I add methotrexate back in? Do I switch to the other 17?
Yeah.
All those things are very random. There's no good evidence to tell us what to do. I can tell you what I do in my own practice. And I would switch within 17 class, unless, especially if they've had a very good response and suddenly stopped. That's very different to if they've had no response at all, then I'd change mechanism of action. And I would mix within 17s, and then I would go to a 23, unless there's a good reason for a TNF, like uveitis, IBD, etc. The JAKs, I think, have got to find their place. And again, I individualized young fit people, no cardiovascular risk factors, no DVT history, blah, blah, blah. And they prefer oral to parenteral. Why not? The evidence is there, they work very well. So I think where I put JAKs in the PSA hierarchy has to come with a little bit more time. But I think the 17s, 23s are very safe, effective drugs. And it depends on the patient sitting in front of you. What are their comorbidities? Did they have a malignancy last year? Did they get chest infections? Have they had lots of herpes simplex? There's a million things you throw into the mix. And I don't think we should be concrete. I don't think we should say you must use this first and that second. If you had lymphoma, I'd be using this. And if you had, so I think it's not as easy as the recipe starts with this and then moves on to that.
Okay. Thank you.
Thank you very much. And by this, we conclude the session. So thanks, everybody.
So good evening. Thanks for being with us late. My name is Raja'i Nammas. I'm a consultant rheumatologist at Cleveland Clinic, Abu Dhabi. I'll be chairing this session. So it gives me the honor to present our next speaker, Dr. Robert Moots. Dr. Robert is a senior UK clinical academic rheumatologist, qualifying in London. He earned his PhD in immunology at the University of Oxford, and he worked at Harvard Medical School before returning to the UK. He established a new academic rheumatology group in Liverpool, where he was the first professor of rheumatology in 2020. He moved his academic affiliation to the newest medical school in the UK. Dr. Robert's research mainly focuses on inflammatory diseases from bench to bedside, and he published extensively with his group in the EULAR, and Dr. Robert advises in the NICE and chaired the panel that devised quality standards of RA, and is a past editor of the rheumatology and lectures in multiple places around the world. His clinical service is a crucial part of his role, and he has extensive experience in managing hard-to-treat rheumatological conditions. And he is a director of the National Center of Excellence for Behçet syndrome in Liverpool, and is a long-standing supporter of development of rheumatology in Africa. And without further ado, Dr. Robert, you'll be presenting talk named Managing Behçet's Disease Complications. Dr. Roberts.
Thank you. Thanks very much for your very kind invitation. It's really good to be here with you. I'm sorry it's only virtual. It would be good to be back across meeting you all. So my task is to say a little bit about managing complications of Behçet's. And indeed, I'm going to cover that. But one of the crucial things about Behçet's is to understand that this is a very poorly defined and very poorly understood disease. And if we're going to be thinking about complications, we've got to know that we're actually dealing with the correct disease. Now, in the UK, pretty well everybody pronounces this disease wrongly. It doesn't really matter. But one of the key things that often puzzles people is, should it be Behçet's syndrome or Behçet's disease? I don't really mind. Strictly speaking, it's a syndrome. Many people call it a disease, but the crucial thing with this is to think of the diagnosis. And that's the really important thing, because I sadly see a lot of people, and I'm going to be introducing a patient to you in a few minutes, where the diagnosis was not made. On the other hand, there are also many people who wrongly have a diagnosis of Behçet's when they have something else. So we've got to start right at the beginning. Now, this person here is not Lucy Behçet. It's indeed a Greek ophthalmologist, Benedictus Adamantiades. This is the person that really discovered Behçet's, if indeed you come from Greece. Of course, if you come from Turkey and the rest of the world, we think of Behçet's because of Hulusi Behçet, and you can see his photograph here, although there is evidence that this disease has been described in ancient times. Initially, the description was of this triple symptom complex of oral ulcers, aphthous ulcers, genital lesions, and inflammatory eye disease. So that's the original description, but how do we make a diagnosis of Behçet's? If we're thinking about complications, which I'm going to come to, we've got to think about getting the diagnosis correct for the disease itself. And the truth is, it's actually quite difficult. Unlike other rheumatological conditions, there's no lab test. If we look at the genetics, well, there are a couple of gene associations, but they're not terribly helpful because they're not predictive either way. The other thing that's confusing is that there are many different diagnostic criteria. It suggests to me, if you have a disease with many different diagnostic criteria, that we probably don't really understand how to define the disease in the first place. But what's important to me is that when we think about Behçet's, we've got to look at a combination of some positive features, but we've also got to exclude other diseases. And there are a number of mimics of Behçet's, ranging from celiac disease through Crohn's, Sweets, lupus, just to name a few. The diagnostic criteria that we use in the National Centre in Liverpool are the 1990 International Study Group criteria, and I've listed those criteria here. Again, this is very simple information, but it's very important because we need to get the diagnosis correct if we're going to be managing it appropriately. So we're looking at recurrent oral ulceration, and to me, that means I need to see the ulcer, either in the patient or a good photograph, because as you know, many different forms of oral ulcers, they can be associated with inflammatory bowel disease, but in Behçet's, we're looking at aphthous ulcers, painful, but also negative things like herpes. The same for genital lesions. We've got to see the right type of ulcer, not just a genital lesion. Again, direct visualization is important. Photographs, if we can't see anything at the time, and that's always a rather difficult thing, asking a patient to take a photograph of a very private area. And the other difficult thing is making sure the patients are swabbed and they don't have any virus there. And then, of course, there's eye inflammation, the skin lesions, and although the textbooks talk about erythema nodosum, the most common type of skin lesion is a papulopustular lesion that looks very much like acne, but is slightly different. And of course, we have a positive pathogy test. That's how we make the diagnosis. But in addition to that, there's got to be no other meaningful clinical explanation. So we have to rule out other conditions. I'm just going to show you the Da Vinci criteria. These are alternative, one of the number of alternative criteria for Behçet's, and that's suggested to be more sensitive, but maybe not quite as specific. if you're using these criteria, these are designed to be used by people who are experts in Behçet's. This is not a simple way of diagnosing it, and this slide shows you why. If we look at the left, the international study group criteria, you need 3 points at least to make a diagnosis, of which one are oral mouth ulcers. And I can show you there the other lesions which accrue points. If we look on the right-hand side with the Da Vinci criteria, if you're very quick with your maths, you'll realize that you can diagnose Behçet's without any oral or genital ulcers. So that makes life a little bit complicated, to say the least. So for a variety of reasons, I tend to advocate the 1990 International Study Group criteria, a little bit more reliable and also a bit more practical if we're looking at this, but we don't have a great experience or a great expertise in Behçet's. Around Western Europe and in the US, this is a rare disease. Of course, in the Silk Route countries, and if you're a romantic, this is where silk was traded from the east into the west. If you're a little bit more cynical, it's where opium was traded in the opposite direction. Far more prevalent, Turkey, Greece, Japan, and of course, through the Middle East. Sex ratio varies by country, epidemiology is relatively poor, but one of the striking things of Behçet's is as a vasculitis, it can affect any size of blood vessel and both arteries and veins. And that's important because I'm going to be talking to you about a particular type of complication of Behçet's. And again, as I mentioned earlier, we don't know what causes it. If we don't really know what causes a disease, it makes it very challenging to think about how we might optimally treat it. So this is a cartoon on the right. You can see a normal artery at the top. And then as we're going down from the top to the bottom, the artery becomes inflamed. And of course, veins also can be involved in this. That can disrupt blood supply, it can occlude an artery, and it can also lead to an aneurysm. This is very important within the context of what we're going to be talking about in Behçet's. When we look at the immunology, then there's almost any type of immunological process, any type of immune cell that's at some stage been implicated in Behçet's, whether it's a lymphocyte, in our case, neutrophils we're interested in Liverpool. If you're looking at cytokines, you can bet that there's some evidence that these might be playing a role in Behçet's. And then when we look at genetic susceptibility, the largest genetic susceptibility is HLA-B51, which is, interestingly, a Neanderthal gene. And HLA-B21 and also ERAP, endoplasmic reticulum loading peptide, these are the two genes most associated with Behçet's, but even so, it's a weak association. HLA-B51 is relatively frequent in people in Silk Route countries. It's rare in the UK, but also in the UK, we see many people who are negative for this. We routinely check HLA-B51. The truth is, I don't know why, because it doesn't really help us when we're making our diagnosis. When I look at people with Behçet's, there are many different complications and many different organs that can be involved. I tell the medical students it can affect any part of the body from the brain down to the big toe. But of all of the manifestations of Behçet's, there are two that really worry me. The first is illustrated here, and this is somebody with neuro-Behçet's. You can see some high signal area in the brainstem of this patient, and that's a typical area for neuro-Behçet's. This is a very difficult disease to treat. In this particular patient, he failed on all types of treatment, including Campath, a variety of other biologics, and ultimately was cured by an autologous human peripheral stem cell transplant. I'm not going to cover that today. I'm going to be covering the other complication that really bothers me, When we think about the treatment of Behçet's, historically, we've been pretty useless. We've given very powerful drugs that have been just causing side effects. And for goodness sake, for many years, thalidomide was one of the so-called best treatments for Behçet's. Thankfully today, treatments improved, but we're very much lacking targeted treatments, sensible targeted treatments. We can talk about that a little later. At the moment, the treatment is eminence-based and not evidence-based. We try and use the lowest dose, the safest drug for the shortest time. And we use a lot of biologic drugs in the UK now for people with refractory disease. We've developed a national drugs pathway, and I won't go into this in any great detail, but the bottom line is we start with simple treatment, topical steroids for mild disease, and we can work up to biologics for the more severe disease. And for very bad organ-threatening disease, our first drug is often a biologic drug because we can't afford to mess about. If you want to look at some relatively recent recommendations, we've published this a few years back. This is the current EULAR recommendations. At the moment, we're in the process of updating this for British Society of Rheumatology and the British Association of Dermatology, but it won't change dramatically. Okay, I want to tell you about one of my most scary complications of Behçet's, and I want to introduce you to Matthew. Matthew's a young lad from Wales, about 2 hours drive away from where we are. He got admitted to his local hospital. He had acute breathing problems, an abnormal chest X-ray, and he was thought to have either had pneumonia, cancer, or, well, they just didn't really know. So he got transferred across. When he got across to us in Liverpool, he started coughing up arterial blood. He was transferred to our intensive therapy unit and underwent emergency surgery. He had a lobectomy for a massive bleed. And this was before he actually got referred to us. He then got referred to us. This is Matthew. I'm going to let him explain, I hope you can see and hear this, a little bit about things from his own perspective. So over to you, Matthew.
I first noticed I was ill when I was about late 19, early 20s, when I ended up getting erythema nodosum on my legs, and that spread sometimes to my arms, depending on when it was coming in and out of remission. And I used to get a lot of yeast infections and ulcers, my breathing, because it affected my blood. It caused a blood clot in my heart, and that snapped off and went to my left lung, which caused a pulmonary embolism. And I sometimes think, could that not have happened if I got diagnosed sooner? But because it's such a rare and complex disease, it takes a while. And they thought I had cancer at first. I got infections everywhere in my ears. I even got one around my left testicle, which was agony. Yeah, I got a lot of ulcers, mouth ulcers, headaches, nausea, lost about 4.5 stone. My GP thought, he initially thought it was just it will burn itself out. I'm young, I'll just grow out of it. But I thought it was, my mum thought that as well, but I knew it was something. I thought it was cancer, but my doctors didn't have a clue what it was. They thought it was pneumonia, but I did have pneumonia due to the blood clot in my lung, but I had a pulmonary embolism.
So a very confusing picture. There's a lot of things going on there, and it's hard to work out what's happening. Let's hear just a little bit more from him.
When I became really ill, what I thought was life wasn't worth living. Like, death wasn't the worst scenario. Do you know what I mean? The worst outcome. It was horrible. I couldn't even, my social life was ruined. I was just bedbound, waiting to die.
So poor Matthew was in a pretty bad state. And the whole picture is very confusing. And it's important that we appreciate the fact that people present in ways that just don't look right. He's mentioned skin rashes, mouth ulcers, genital ulcers, but also infections, headaches, blood clots. He was acutely ill when he was admitted. And the clinical picture when he was referred, they just didn't know, was this a strange pneumonia? Was it a lymphoma? Was it emboli? Either way, he had a massive hemoptysis. And also, he got a missed deep vein thrombosis. Here we can see a pulmonary CT scan, a transverse section of his chest. And you can see here that there are three quite large, in fact, there's more than three, but I've highlighted here pulmonary emboli. So it's clear that Matthew had pulmonary emboli. And of course, we'd found a deep vein thrombosis, which was probably the source of that. But hey, when we look a bit closer and we see this section of the CT scan of his thorax, there's something funny going on. Here you can see it's not his kind of diaphragm. There's some really strange mass. And this mass was thought in the other hospital to maybe represent a lymphoma. But hey, here's his left pulmonary artery. And his left pulmonary artery is abnormally broad. It's got an aneurysm. And again, if we look carefully here, we can see actually the active bleeding from his aneurysm in the left pulmonary artery on top of the pulmonary emboli, but a bleed into that huge, big hematoma. And then when we do an ECG-gated examination of his heart by CT, we can see a number of thrombi in the wall of his heart. So Matthew's pretty ill. He's got a deep vein thrombosis. He's got pulmonary emboli. He's got a large intramural thrombus in his heart. So what would you do? Have a think. It's a strange situation, isn't it? Thrombotic disease, embolic disease, hemorrhagic disease, major disease. Not very easy if you're in the emergency room with somebody being admitted. Not very straightforward if you're a rheumatologist and you've been asked to consult on a patient like this. Let's quickly find out what happened to Matthew.
When I was getting admitted to different hospitals and come to Liverpool, I didn't know what was going on. I just don't know, because the doctors didn't know what was going on. So I just thought I had cancer, because that's what they said in Wales. And because my nan died of lymphoma, they said I had it, so I thought it was that, which you would. And then I met you, and then you said it was Behçet's, and I've been all right ever since. When I first realised I had Behçet's, I first wanted to know, could I die from it? And that answered, it had already been answered. I had died from it. Do you know what I mean? And I just wanted to know, was it curable? And is it treatable? And it is treatable, but it's not curable. And I thought, for my own peace of mind, to not look too much into it, because it would just make me paranoid. Just what I know already is I know enough about it. And everyone's different with Behçet's. Not every same case is the same. Not every one case is the same. From when I first started the treatment to now, I've felt like I've had my old life back. My life, I've picked up my life from when I was 16 and I'm now 25. That's how much Behçet's has had an impact on my life, but I've learned a lot of lessons through Behçet's and meeting you and all the team in Aintree. I'll remember it for the rest of my life.
And let's hope, Matthew, that's going to be a long time. I want us to get out from that a few things. First of all, when we see people with Behçet's, the story is often confusing. When we see people with Behçet's and they have a really dramatic, life-threatening and organ-threatening complication, again, it's not straightforward. So if you see somebody with Behçet's and they've got a deep vein thrombosis and they've perhaps got a pulmonary embolus, what are you going to do? And the key question is, are you going to anticoagulate them or not? Now, a knee-jerk response to deep vein thrombosis is to anticoagulate. I mentioned before, we don't really know how to treat Behçet's, and there has been a debate for a while about whether or not we should anticoagulate in this situation. The key thing is to make the diagnosis. That's why I've labored the background to Behçet's, labored making the diagnosis. Of course, we've got to treat the patient as a whole, because every bit of the body can get involved. It's good to have a multidisciplinary team. And one of the important reasons why we set up a national centre in the UK is that in difficult situations like this, there is an expert available on the end of a phone or an email, and phoning a friend can make a very big difference in the management and give a lot of confidence when you have this difficult situation. So how do we treat vascular Behçet's? Well, there are three important principles. Number one, control the inflammation. Number two, control the inflammation. And number three, control the inflammation. Don't give anticoagulants. That was one of the problems with Matthew. When people have vascular Behçet's, they're at risk not just of having an irritated endothelium, which is causing the deep vein thrombosis, but also inflammation in the arteries, particularly the large arteries, particularly pulmonary arteries. And if there are large pulmonary artery aneurysms and we anticoagulate, then death can happen pretty rapidly. And that's what had happened to Matthew. He got pulmonary artery aneurysms. He was anticoagulated for a deep vein thrombosis. He bled dramatically. And actually, he was very fortunate to have survived. And the way that we control inflammation is initially high-dose pulsed intravenous steroids. And in Matthew's case, we put him pretty well immediately on infliximab. And this is now 5-6 years since we recorded this. He remains in extremely good health, but was very, very close to death with this very nasty complication. So you asked me to talk about complications of Behçet's. I've only spoken about one, but this is the one that we often get wrong. We don't know what causes Behçet's. We have a poor evidence base for treatment, but the good thing is that, at least in the UK, we now have a national cohort. We've been doing a number of trials. We just finished the Behçet's trial, looking head-to-head of infliximab against alpha interferon, and we're about to report on that soon. And we're about to start a trial of other biologics in Behçet's. And the hope is we'll move away from eminence-based treatment to evidence-based treatment. One of the things that's made a huge difference is a multidisciplinary clinic of experts from different specialties, all in the same place, around the same patient, helping sort out diagnosis and treatment. And the one thing I want to have you take away from this is be careful, beware of anticoagulating people with Behçet's if they have vascular disease. Sometimes it's hard to not anticoagulate. It's a knee-jerk response. My friends in Turkey have actually got a good series of people, some of whom have had anticoagulants, others haven't. Of course, all have had immunosuppression, and the people without the anticoagulants have done better. So don't forget about Behçet's. Don't forget that the story for Behçet's can often be a little atypical. Think about the diagnosis, and then if that's what the diagnosis is, be brave, immunosuppress, and beware about anticoagulation unless you've got good angiography and you can see no evidence for large vessel disease. Thanks very much for listening, and good luck with all of your Behçet's patients.
Thank you, Dr. Roberts, for addressing a very challenging manifestation of Behçet's that we honestly we see in the here in United Arab Emirates. Have a question?
Thank you very much. Excellent lecture. For patient who coming with the classic patient, oral and genital ulcers or arthritis, who failed to improve with the steroid, requiring higher dose of steroid despite full dose of Imuran and adalimumab even. And you keep, whenever tapering steroid, getting flare. So what's the next after that?
That's a great question. Thank you for that. So there's very little evidence base for other biologics in Behçet's. In the UK, we're in the process of moving to a kind of a broad phenotype base for how we're actually targeting other biologics. So one of the drugs which worked phenomenally well was Rofiron. Unfortunately, that drug is no longer manufactured anywhere, apart from, I think, some place in Iraq that manufactures a biosimilar. That would have been a good option for many cases if they could tolerate the adverse effects. If you're looking at vascular disease, then we would recommend tocilizumab. If you're looking at predominantly kind of inflammatory bowel variant of Behçet's, then we could be looking at ustekinumab or that type of targeting. There's been an interesting report from colleagues in Italy about the potential for IL-17 inhibition in Behçet's. So we've actually set up and we're about to start a national trial looking at secukinumab in Behçet's. But the bottom line is once you've failed on steroids, on Imuran, simple immunosuppressants, moving on to a biologic, that's the choice. When all of that fails, we have the largest series in the world of people with human peripheral stem cell transplants. So human stem cell transplantation is extremely successful in very refractory Behçet's, but unfortunately, there's a significant mortality associated with that. So we're very careful before we would do that.
I think we have a couple of questions here. Maybe we'll give a chance.
Thank you. That's an excellent talk, Dr. Muth. Now, your patients, it's really rare to have PEs in Behçet disease. And especially in UK, there was series showing, the only UK series showed there is incidence of PEs in Behçet disease, but that series contained also patients on oral anticoagulation. Now, this lesion in your patient's lung, why they are not in situ vasculitis? Why they just in situ thrombosis rather than they are coming from his legs actually? Because we know DVTs or these in situ thrombosis in the legs, usually they don't dislodge easily. So just wanted to elaborate in this. And the other thing that if you have a patient who having, for example, you think he's having DVT, do you do CT imaging to see whether they have occult aneurysms, because they are not necessarily symptomatic. They could have only small tiny aneurysms which can easily bleed. Thank you.
Yeah, great questions also. I'll answer it in reverse order. First of all, yes, we do detailed angiography. It depends a little bit about what your radiologists are like. MR angiography is preferable, but now you can get pretty good definition CT angiography. So as a minimum, we do CT angiography because we can get that done quickly, and that's much more straightforward and easy. With regards to emboli, you're absolutely right. There's something slightly strange that in the UK, we do see that. We don't see it very often, to be perfectly honest. It's normally localized. Of course, one of the other things to bear in mind that when we see lesions within large arteries, that actually could be an arterial thrombus rather than something that's broken off from a peripheral one. So either way, it's kind of telling us that we need to be looking at large vessels, not just at the legs. In Matthew's case, the patient I presented, that was not difficult. But in other situations, you can have subclinical arterial problems, which is very important to be looking for.
Thank you very much. We have a couple of questions here from the audience. If patient has Behçet's, if patient with Behçet's has acute DVT, do you recommend anticoagulation?
No.
And
That's a very simple answer. The truth is always a little bit more complicated. And one of the things is to be taking a good history, looking at what else is going on. Are there active signs of Behçet's being active in other parts of the body? How certain is the diagnosis? But if all of those things are there, it's definite Behçet's, there's clear disease activity, then I would caution against anticoagulating for the reasons I said, and it would be mandated to immunosuppress.
And this is followed by another question. If patient has Behçet's on anti-TNF, refractory to anti-TNF, what's your next choice?
Again, it's a tough one. I mentioned earlier a few other biologics that there is emerging evidence that could be useful. So those would be the things I'd be thinking of, ranging from secukinumab to tocilizumab, ustekinumab, depending a little bit on which organ is being particularly involved.
And this is followed by another question that if they're refractory to anti-TNF, do you favor JAK inhibitors? Any role of JAK inhibitors in patients with Behçet's?
That's a tough one, that. There's very little experience, very little in the way of anecdotal reports. One could argue immunologically either way. Certainly, some of my friends, Ahmed Gul, would suggest it's not a very good target. Other people feel that it's worth looking at. The truth is, when you're desperate and people have failed a whole range of drugs, it's very tempting to have your patient do the experiment for you. But there's not much evidence to suggest that could be good.
I'm just curious, for Matthew, what kind of, which immunosuppression did you choose? Did you go with TNF or cyclophosphamide?
Well, we went for TNF. We gave 3 grams intravenous pulsed methylprednisolone to start off with, and then infliximab. We like infliximab for this situation because you're getting a good peak plasma concentration with the infusion. Cyclophosphamide would be a legitimate alternative, and you'll note I hadn't even mentioned cyclophosphamide. And that's basically because with the National Centre, we have the funding for biologic drugs in the UK for Behçet's. And if it were me, I would rather have infliximab than cyclophosphamide, assuming that both would be equally effective. And that's our experience.
I think with this, there's more questions, but it's about ocular manifestations and other manifestations. So I think with this, we'll end this session. And thank you very much, Dr. Roberts, for this fruitful talk. We learned a lot.
Thank you.
So our next speaker is Dr. Pooja Mehta. So Dr. Pooja is a rheumatologist and is undertaking a basic science PhD in post-COVID interstitial lung disease at the University College of London, respiratory division. She's a strong proponent of cross-specialty working and has wide clinical practice. Her main research interests are rheumatic associated interstitial lung disease and immunotherapeutics. She has an experience in drug development and the industry academic interface, having designed a clinical trial in rheumatoid arthritis during a pharmaceutical industry fellowship and a background in academic hematology. She's a member of the COVID-19 EULAR task force and is current clinical chair of Early Career Research Network Committee and a member of the Athena Swan Committee at UCL. She supervises and teaches Masters in Science and medical students at UCL and Imperial College. And today, Dr. Pooja will be presenting COVID-19 cytokine storm impact on patients and clinical application in daily practice. Without further ado, Ashish, it's the floor is yours.
So I think I'm a little bit short. I'd just like to start by thanking the organizers for the invite. It's such a pleasure to be here in Dubai. I last came here 10 years ago and so much has changed. This is an update of the talk that I gave at the ACR last year, and I'm going to be focusing on immunotherapeutics. These are my disclosures, which are not relevant to what I'm discussing today. We'll start with the rationale and hypothesis for immunomodulation in COVID-19 with a high-level contextual overview of established cytokine storm syndromes. We'll move on to immunomodulatory drug trials, the approved dexamethasone, interleukin-6 antagonists, and JAK inhibitors, and cover other candidate cytokines, namely IL-1 and GM-CSF, and then we'll end with future directions and unanswered questions. Thank you so much for staying till the end, and I'll try and be as quick as I can and finish on time. So I'm going to start by taking us back to 2 years ago. We were faced with an unprecedented clinical challenge. The outlook was very bleak. There was huge uncertainty about treatment, many candidate drugs and opinions, and no reliable data. For most patients, this was a self-limiting illness, but with a very high mortality if hospitalized. Very early on in the pandemic, I had an idea, and we wondered whether hyperinflammation was contributing to poor outcomes in some patients with severe COVID-19, given that there were clinical similarities to secondary HLH, hemophagocytic lymphohistiocytosis. Viruses are the most common infectious trigger of SHLH, and early reports from China suggested that a cytokine profile and biomarkers known to be important in SHLH associated with COVID disease severity and predictors of fatality. And with that rationale in mind, at a data-penic time, we suggested that all patients with severe COVID should be screened for hyperinflammation. We now know that the H-score for HLH is not useful in COVID to identify this group of patients, and that IVIG or convalescent plasma are not effective. But we do have evidence for the efficacy and safety of steroids, tocilizumab, JAK inhibitors, and even anakinra in certain populations that I'll talk about later. We weren't the only group to suggest this concept, and there's a very nice paper along the same lines by US International MAS Collaborative, of which I'm also a member, about a month after our paper. The proposal that hyperinflammation was involved in the etiopathogenesis of severe COVID served as a catalyst for numerous clinical trials of immunomodulatory strategies in this space. However, this was appropriately challenged, and there were a lot of Twitter storms as well. Some questioned the definition and the very low IL-6 levels. There were concerns about the risks of immunomodulation with potential viral resurgence or bacterial or fungal superinfection, that we could be compromising antiviral immunity, and that worse outcomes were observed with steroids in previous pandemics with other coronaviruses. There was also a suggestion that we were distracting focus from antivirals and vaccines. The term cytokine storm has been very emotive and polarizing, and Professor David Feigenbaum and I summarized that hyperinflammatory debate in a review. It is now abundantly clear, there's been so much discussion and literature about IL-6 concentrations in severe COVID being quite low, elevated, but low compared to other critical illnesses, especially cytokine release syndrome post-CAR T cell therapy. But I just want to remind us that it's important to remember that systemic levels measured in the blood may not accurately reflect the local disease microenvironment, the pulmonary compartment, shown in this figure here, where IL-6 levels in COVID, in purple, are significantly higher in the BAL, the bronchoalveolar lavage fluid, compared to the blood. And we all know from rheumatology practice that IL-6 levels and CRP do not correlate with response to tocilizumab in rheumatoid arthritis, for example. So severe COVID-19 does meet the definition that was proposed in the New England Journal of Medicine for cytokine storm syndrome. Here, David Feigenbaum and Carl June describe immune dysregulation with elevated cytokines, deliberate omission of specific cytokines or thresholds given the dearth of data, acute systemic inflammatory symptoms, and secondary organ dysfunction disproportionate to the initial trigger. The umbrella term, cytokine storm syndrome or hyperinflammation, is a unifying catch-all demonstrated in this really nice figure with COVID-19 as a distinct entity residing under the cytokine storm umbrella. In brief, the etiopathogenesis of cytokine storm syndrome is not fully elucidated, but it's thought to occur in an immunogenetically susceptible individual, we'll come to genetics later, where a trigger, such as a virus like SARS-CoV-2, results in a dysregulated immune activation with exaggerated autocrine loops of pro-inflammatory cytokines, the so-called cytokine storm, and this gives rise to clinical sequelae that we all know about. And I just want to remind us that these are all druggable therapeutic targets with existing therapies with known safety profiles. In our framework for management of conventional cytokine storms, we suggested switching off the cytokine storm with immunomodulation in an induction maintenance treatment paradigm and concurrently treating the underlying cause and any complications that may arise. So how does this all relate to COVID? Well, a biphasic model of COVID-19 is now well established, with an initial viremic phase, followed by an overlapping host hyperinflammatory phase at around day 10 in a subgroup of patients with an exuberant dysregulated immune response associated with high mortality. And this is my favorite figure of the pandemic. You know that there's been so many papers, and out of all of them, this still remains my favorite because it elegantly encapsulates the complexity and need for strategic timing of immunomodulation to maximize benefit and minimize harm. And this is really tricky. The immune response in COVID may be helpful, antiviral, or harmful, hyperinflammatory. And to me, it feels like there's a Goldilocks immune response to COVID. Too weak, where there's dominant viral damage to the host. Too strong, where there's hyperinflammatory host damage to the host. And just right, where there's appropriate host antiviral immunity and symptoms are mild to moderate and controlled. There have been numerous trials in COVID-19 over the last 2 years, multiple opportunities for therapeutic intervention. We've had antithrombotics, antivirals, neutralizing antibodies, immune stimulants. And for today's talk, we're going to focus on immunomodulation or immune suppression. There have been an avalanche of observational studies and interventional trials in this space, and these are just some of the drugs that have been trialed in COVID. For the large part, this was a mechanistic repurposing of existing therapies, biologics or small molecules, as well as assets in clinical development like GM-CSF that I'll come to shortly. Most of our evidence that we're now enacting in clinical practice has come from large platform studies. So I just wanted to summarize what these really were. A Recovery was a large randomized controlled open label platform trial in the UK. And these were hospitalized patients with proven or suspected COVID, randomized to no additional treatment, host-directed therapies, or antivirals. The primary endpoint was a 28-day mortality. There was a simultaneous second randomization to convalescent plasma. So for example, a patient may have had control and no additional treatment, so nothing at all, or dexamethasone and convalescent plasma, for example. There was also another second randomization for patients with more severe disease, and this was demonstrated by hypoxia or a raised inflammation marker, CRP of greater than 75 mg per liter, to either tocilizumab or control. And over time, many other drugs have been added, including a comparison with high and low dose steroids, which is eagerly anticipated. The other very large trial is REMAP-CAP, which is a global, randomized, embedded, multifactorial, adaptive platform trial for community-acquired pneumonia, which was ready and waiting for the pandemic and was expanded for COVID. And it's important to note that this is a different population to Recovery. So REMAP-CAP patients were all in an ICU setting. They all had organ support and were within a 24-hour window of ICU admission. So it's a very specific population. They had an immunomodulation arm, and over time, again, lots of other things have been added. Let's look at steroids first. Now, we all know that dexamethasone was associated with a reduced 28-day mortality in patients on supplemental oxygen, which was more pronounced in those who had invasive mechanical ventilation, with a suggestion of harms, you can see the confidence interval crossing 1, in those not on oxygen, all supporting the concept of hyperinflammation in the patients requiring supplemental oxygen in severe disease, but not in not severe disease. The steroid response from recovery was validated in REMAP-CAP's hydrocortisone arm, which was terminated or amputated 1 day after the recovery readout, and therefore statistical significance was not reached for this reason. Trends were confirmed in a meta-analysis demonstrating effects on 28-day mortality with a reassuring safety profile. And then in September 2020, the World Health Organization recommended steroids for COVID patients who were hospitalized requiring supplemental oxygen. And this was fantastic because dexamethasone is cheap and widely available. Before I move on to other drugs, I just wanted to take a step back and reflect on how we interpret clinical studies. It's not straightforward to celebrate or commiserate a so-called positive or negative trial in inverted commas. A lack of treatment response doesn't always refute the efficacy of a drug because it depends on a number of factors, including the study design, whether it's open label, REMAP-CAP and recovery were both open label, and components of the PICO framework. So P stands for population, the criteria. Did they have hyperinflammation? How was hyperinflammation defined? What was the CRP cutoff? It varied in all of the different trials. Were they enriched for hyperinflammation? In terms of the intervention, timing is really important. So the timing at which the intervention was initiated, both relative to the time of infection, as well as the severity of inflammation. And is there a window of opportunity that we illustrated in this figure here in the Lancet Respiratory Medicine? Intervening too early may be harmful. There was a suggestion of harm with dexamethasone in patients not requiring supplemental oxygen. And intervening too late may be potentially futile. The dose is important, the dose, duration, route of administration, and probably best exemplified by anakinra. The IV versus subcut dosing of anakinra is really different. See, the comparator is really important. Standard of care definitions changed over time. We had different accrual of clinical experience, improved supportive care, and advances in background therapies. And we all know that steroids became standard of care after July 2020. So when was that particular clinical trial active in terms of calendar months? And the primary outcome, the O, is also very different. Co-primaries are usually harder to achieve. So now we can finally go on to IL-6 inhibitors. And the concepts that we've just discussed were really important when we were scratching our heads over the swinging pendulum of positive in orange and negative in gray IL-6 receptor antagonism studies. And it felt like REMAP-CAP and recovery captured that sweet spot. But let's take a closer look at Covacta, which was negative in inverted commas, and REMAP-CAP, which was positive in inverted commas. So why was that? Both these trials were published in the New England Journal of Medicine, a very stellar publication. Covacta was this negative, traditional double-blind trial. REMAP-CAP was open label, and that could have influenced clinical decision-making. REMAP-CAP patients were possibly more severe. These patients, remember, were all in an ICU setting within this 24-hour window, but probably the most important factor is the steroids. So you can see that standard of care was different across the two trials. About 25%, let's say, in Covacta had steroids, reduced in the tocilizumab arm compared with the placebo, but 90% of patients in REMAP-CAP received steroids. And in recovery, 82% of the tocilizumab treated patients received steroids, and it's probably made the biggest difference. A meta-analysis of 27 RCTs of IL-6 inhibitors in patients hospitalized with COVID confirmed a lower 28-day all-cause mortality with IL-6RA. But that significant mortality benefit was only seen when combined with steroids, perhaps a synergistic effect. And the greatest benefit was in those that needed supplemental oxygen earlier in the disease course compared with invasive mechanical ventilation. And there was no difference with age, sex, race, ethnicity, cardiovascular support, but importantly, the CRP, which did not influence outcomes. And the safety was very reassuring, but the important thing to remember that the safety data only went up to 28 days post interleukin-6 receptor antagonism, so we don't have any data beyond that. And it was limited in some trials. So in March 2021, almost 1 year ago today, the NIHR recommended tocilizumab in combination with dexamethasone for COVID patients, pretty much the REMAP-CAP and recovery inclusion criteria combined into one. So an ICU setting, supplemental oxygen, rapid increasing oxygen requirements, and markers of inflammation. So remember, recovery was the ICU remap cap was the ICU setting, and recovery required a CRP of at least 75. Moving on to JAK inhibitors. So Act 2 was around 1,000 patients. These were not on steroids, and baricitinib reduced the time to recovery by 1 day in combination with the antiviral remdesivir, which was more pronounced in patients on high flow oxygen or NIV. Convergence was a double-blind RCT of 1,500 patients on oxygen, excluding invasive mechanical ventilation, and 80% were on steroids, so that's important. Now, very interestingly, they did not meet their primary endpoint, which was progression, and they probably thought that they had insufficient power to select mortality as a primary endpoint, but this was actually met as a key secondary. Baricitinib caused an absolute reduction in mortality of 5%, which is really very exciting. And the NNT, the number needed to treat, was 20 at day 28 and day 60. And again, we have a theme. The greatest benefit was in patients with supplemental oxygen. Act 4 is really exciting. We don't have the final publication, but we've seen preprints, and it was terminated early for futility, which suggests non-inferiority of baricitinib to dexamethasone in combination with remdesivir. And could baricitinib be placed in place of dexamethasone rather than in addition, particularly in patients at risk of steroid side effects, but we want to wait for the full paper before drawing any conclusions. Now here I put, we're awaiting the results of recovery, and actually some of you may have noticed that I think just yesterday the preprint was published for recovery. So any COVID paper or presentation that you do is out of date as soon as you press save, and you can see that it was positive that baricitinib was reduced, did associate with a reduced mortality in recovery, but we need the peer-reviewed paper before again making any firm conclusions. But it really is looking very, very positive for baricitinib, which is exciting and in keeping, consistent with all of the other studies. Tofacitinib was also positive in Stop COVID. It was superior to placebo, reducing the incidence of death and respiratory failure. And baricitinib was added to the World Health Organization Living Guidance on COVID trials and treatments. Tofa and ruxolitinib are alternatives if baricitinib is not available. And I'd really recommend this resource in the BMJ, the British Medical Journal. It's really user-friendly and it's a very nice reference. Moving on to IL-1. Now, canakinumab inhibits IL-1 beta. It did not improve survival in this paper published in JAMA. And I just want to remind us that anakinra is an interleukin-1 receptor antagonist. So it blocks the activity of both IL-1 alpha and beta. And we talked a little bit about pharmacokinetics earlier, IV versus subcut. IV dosing of anakinra results in a 29-fold higher maximal plasma concentration with a shorter half-life compared with subcut. And you're not supposed to be able to read this table. I don't think anyone can or should, but it demonstrates the considerable heterogeneity of PICO in anakinra trials in COVID. And the take-home message is that the anakinra trials are very difficult to compare because they're all incredibly different. There were some promising cohort studies with historical controls early in the pandemic, both retrospective and prospective, but RCTs of anakinra have been mixed. And again, let's try and see why. So core immunoANA was open label, it was negative. And Save More was positive and did result in a reduced mortality, a 55% relative reduction in mortality. The population in core immunoANA was mild to moderate. The CRP threshold was only 25, that's really low. Whereas in Save More, they had a very innovative trial design. So they enriched for this biomarker called SUPAR, which I'll come to later. And 90% of patients had severe pneumonia. Really importantly, the anakinra dosing regimen was very complex and variable in core immunoANA. And very interestingly, in Save More, which was positive, it was quite low. So 100 milligrams subcut once daily is really quite low. And very excitingly, we have, again, that steroids were variable and quite low, limited in core immunoANA, but about 86% in the positive save more received steroids. So we're getting this theme of a severe patient population who are concomitantly provided with steroids having a positive outcome. But it's not as straightforward as this, because another trial called Anaconda was suspended due to safety concerns. And we're awaiting core immunoANA 2 in an ITU setting, remap cap anakinra arm, which the dosing may have influenced outcomes. And just a couple of months ago, there was a positive opinion from the CHMP of the EMA regarding anakinra. So we're eagerly awaiting this space. I just want to talk a little bit about GM-CSF inhibition. So for me, GM-CSF exemplifies the complexity and drug trials challenges in COVID-19, because there's rationale for giving GM-CSF and stimulating the immune response, but also blocking it. And therefore it becomes very confusing, as GM-CSF has roles in homeostasis, antiviral immunity, and hyperinflammation. GM-CSF correlates with disease severity, and unlike IL-6, it's elevated in fatal COVID, but not fatal influenza. GM-CSF expressing Th17 cells in the bronchoalveolar lavage are key mediators of lung injury in COVID. So it's definitely important, but the trials have been really mixed. And we summarize this in this editorial and this table. There have been negative trials with mavrilimumab, which affects the receptor rather than the ligand. GSK's OSCAR trial was also negative. We've had a positive trial of lenzilimab, live air, which resulted in improved survival in this graph here, in a patient population that had a CRP of less than 150, so a low CRP, which is slightly counterintuitive, but may suggest that GM-CSF is involved in early initiation of inflammation. So that's just an interesting way to think about different cytokines and how they're involved differentially. The other trial that was positive, in inverted commas, was Catalyst, namilumab, the anti-GM-CSF, but not infliximab, anti-TNF, met the primary endpoint, but the primary endpoint here was a delta CRP. So how clinically meaningful is that? Although their key clinical secondary outcomes were met, and namilumab is going forward in recovery. So we'll see what that shows. So I just want to end with future directions. Now, we have host-directed therapies. We've talked about dexamethasone, JAK inhibitors, and IL-6 receptor antagonists. But look at the reduction in mortality. It's fairly modest, and we can't predict which patient is going to respond to which drug. Do we need better drugs? Is it the IL-1 blockers that we've been looking for, the GM-CSF blockers, or better patient selection to predict which patient's going to respond to which drug? And can we, from heterogeneous phenotypes, identify subphenotypes and molecular endotypes to enrich clinical trials with treatable traits? There's also a lot of challenges. The cost of the drug, geographical availability. So anakinra, for example, is not available in India, whereas JAK inhibitors are. And what about our chronic rheumatology patients that require these drugs to control their chronic inflammation? Are we going to use them all up with COVID? Then what do we do? So we already have a very robust score to predict risk of mortality and deterioration in hospitalized patients, the ISARIC 4C, which was based on a massive discovery and validation cohort in the UK. And they do have clinical and laboratory criteria, but we really need to identify the subgroup of patients with hyperinflammation in COVID to try and predict response to immunomodulation. And here I just want to show you that severe COVID-19 is a cytokine storm, but it's very different to the established cytokine storms. We couldn't use our conventional scores that we use for familial cases, HLH, or SJIA MAS. It was very different. Lung dominance, thromboses, which are likely to be immunothromboses, lymphopenias, high CRPs, and quite modest ferritins. There have been lots of studies trying to define what COVID hyperinflammation is, but they're all very different. They have different definitions, either based on multidisciplinary team review, literature review, or empirical derivations. And is this just suggestive of a confirmation bias of the authors? Are we looking at hyperinflammation or just severe disease? We don't know. We need to validate all these criteria together and see which one works best to predict responses. And therefore, currently, the clinical application is unclear. There have been very nice studies to look at biomarkers distinguishing critical COVID from SHLH-MAS. And we can see that COVID hyperinflammation is distinct. It's different to established cytokine storms, but what does it actually mean? What does it mean if we have a low soluble Fas ligand in COVID, but not in SHLH-MAS? So the clinical translation is unclear. We know that there are many poor prognostic factors for COVID. Do these obesity, diabetes, CKD, hypertension actually reflect a pre-existing chronic inflammatory state or a lower threshold for the development of organ dysfunction? How do genetic polymorphisms influence therapeutic response? So we know that there are at least 2 critical COVID mechanisms identified by GWAS studies, important in antiviral defense and host hyperinflammatory lung injury. But what do they actually mean? I wonder whether TYK2 could indicate a response to JAK inhibitors. Could DPP9 indicate an inflammasome targeted therapy like anakinra? We really don't know. There's been lovely work by John Laurent Casanova and Paul Bastard and colleagues looking at interferon responses. And we know that there are antibodies and type 1 interferon genetic problems in COVID and signatures. But what do these mean? Autoantibodies and interferon responses, how does this actually relate to what we're doing in terms of treatment? We don't know. And what about biomarkers? So the CRP is interesting. We need to move towards precision medicine approaches, but how does the CRP help? It's really not very clear. Array CRP may indicate a better response to steroids. There was one study that showed if the CRP was greater than 200, there was a reduced rate of mortality and need for invasive mechanical ventilation. Another study showed that if the CRP was greater than 100, you had a reduced mortality. Better still, if the oxygen was low as well. But the CRP with respect to IL-6 blockers is not helpful. Both tocilizumab and recovery, the meta-analysis did not show any association. And what about ferritin? So a pre-specified post-hoc analysis of COVACTA, which was the negative trial, showed that ferritin, more than any other biomarker, predicted response to tocilizumab. But how have they done that in REMAP-CAP or recovery? We don't yet know. And now finally, SUPAR. So maybe it's not CRP at all. SUPAR is the soluble urokinase plasminogen activator receptor, and it's an emerging biomarker of impending respiratory failure, inflammation, organ damage, immunosenescence. Particularly important in COVID, it may be an earlier predictive biomarker, and it could indicate the presence of DAMPs and an inflammasome response. SAVE MORE was the positive trial that we looked at earlier, which was published in Nature Medicine. And I just want to point out that in this very selective population enriched for SUPAR, the CRP, IL-6 and ferritin were very low. So they're probably not very useful. And actually the authors looked at this and the CRP or ferritin did not predict response to anakinra. SUPAR is great, but not everyone can do it. And I'm not sure where if you work, you can request it. There is a point of care test available, but not many people can get it. And therefore, in the supplement of the paper, they tried to create a model to predict response using CRP, neutrophil to lymphocyte ratio, ferritin, and the liver enzyme AST, but we need some more data about this. So there's lots of unanswered questions just before I end. How does the pattern, severity, and mechanism of hyperinflammation in COVID influence endothelial activation and the hypercoagulable state? Does immunomodulation reduce thromboses? And it's interesting, we just had a talk by Prof. Moots, because in this paper here, we literally likened COVID-19 immunothromboses to Behçet's, saying we need to target that vessel wall inflammation to reduce the in situ thromboses and reduce the risk of thromboses because of the inflammation. What about long COVID? So we know that patients with long COVID severity have a greater proportion of a CRP greater than 10 milligrams per liter. But how does that relate to hyperinflammation in the acute phase? We don't know. And it looks like vaccines are reducing the risk of hyperinflammation, particularly in the adolescent or pediatric populations, so MISC, which is multi-system inflammatory syndrome, or PIMS-TS as it's sometimes known. And that's really very exciting and very reassuring. So in conclusion, this started from a very early data-deprived hypothesis of cytokine storm as a mechanistic basis of critical COVID pathogenesis. And given the success of immunomodulation, it's now clear and accepted that a subgroup of patients with severe COVID have a dysregulated immune response. Dexamethasone, interleukin-6 inhibitors, or JAK inhibitors are standard of care for COVID, but we don't have a head-to-head. We don't know which drug to select, and how are we going to position IL-6 blockers versus JAK inhibitors? How are we going to pick between the two? And we need more data on targeting IL-1 and GM-CSF. Hyperinflammation in COVID is real. It's a new and distinct entity, and several criteria have been proposed, but we really need multivariate models and immune profiling to try and identify the group of patients to predict responses to immunomodulation. Biomarker discovery needs to move from prognostic to predictive to optimize therapy. And we've talked about SUPAR, this companion biomarker for anakinra. The impact of host factors such as genetics, interferon signatures, and autoantibodies are unclear, but it looks exciting in terms of vaccines reducing hyperinflammation. And there's been a lot of debate about different variants with respect to hyperinflammation, and it's not entirely clear. So I'd just like to end by saying thank you to several people who've inspired and encouraged over the last 2 years, and thank you for your attention. I know it's been a long day, but thank you for listening.
Thank you, Dr. Pooja, for this excellent talk. It's a very challenging topic and a lot of unanswered questions, as you mentioned. Dr. Walid has a question.
Yes, thank you very much for a very nice presentation. So the first question is, do we understand COVID now? And how do you categorize patients upon, admission to ICU? Who gets what?
So the first question is hard. Do we understand COVID? I think we understand bits of COVID better. And with respect to hyperinflammation, it looks like there's an acute hyperinflammatory state occurring about day 10. And we've talked about the biphasic response. So initial viremia, and then in some patients, maybe in the immunogenetically susceptible, they have this acute hyperinflammation with immunothromboses, oxygen requirements, and they get really sick, and they're the ones that need immunomodulation. We also know that there's a delayed hyperinflammation phase, and that's in the children called MISC, or in adults it's called MIS-A, and that occurs several weeks after COVID, and sometimes patients are seronegative, so there's no actual evidence of confirmed COVID. And that probably is molecular mimicry in terms of antibody responses and cross-reactivity of antigens. And they look hyperinflammatory, they respond to immunomodulation, steroids, IVIG, and so on. And then we do have a small subgroup of patients that develop HLH, very classical HLH, very high ferritins. They look just like HLH outside of COVID, triggered by EBV, for example, or sepsis. And we treat those just as we do with other immunomodulation like anakinra. So those subgroups of inflammation, I think, are getting better understood. But it's really not clear exactly what's causing each of the phases and how to treat them. So we're empirically throwing different immunomodulators at people. With respect to the ICU question, clinically on the shop floor, well, we have very nice protocols, and I think we're probably all using the similar sort of criteria to identify severity. So the respiratory, in the UK, we tend to use the ISRIC 4C, and that is a composite of clinical and laboratory criteria, but mainly oxygen requirements and the CRP. We give these patients that are severe dexamethasone, but how we decide whether to give them tocilizumab or sirolimus if that's not available, or a baricitinib, ruxolitinib, tofacitinib, that's not clear. A rule of thumb tends to be that if someone is at greater risk of infection, we might give them a JAK inhibitor because it has a short half-life, and therefore if they develop a life-threatening secondary bacterial fungal infection, we can stop the JAK inhibitor, it washes out faster. And maybe the pregnancy issue. Now, I've had a lot of discussion about this because we've heard from our first speaker, or second, I think, that neither tocilizumab or JAK inhibitors are recommended in pregnancy, but this is a life-threatening condition. So if a pregnant patient develops severe COVID, we want to save their life. And there's some feeling in terms of consensus, eminence-based, that tocilizumab might be safer than the JAK inhibitor. I don't think that's evidence-based, but in a pregnant woman, we've been tending to give steroids plus an IL-6 inhibitor rather than a JAK inhibitor for no good reason, I must say. So I hope that answers your question.
Yes, with
Yeah, we can go last question, just due to timing.
thank you very much. With the maybe similar mechanism, but with vaccine, those patients who develop autoimmune reaction with vaccine or traumatological, or sometimes even autoimmune neurological, or flaring of the disease. So with the first or the second vaccine, so any precaution for the third or fourth with such severe reaction patient get?
So I think just because I think your mic is a little bit low, the question is about adverse events of vaccines and if we know what the mechanism is.
No.
Oh.
For those patients who develop severe reaction to vaccine, either flaring of the rheumatologic autoimmune disease or getting a severe autoimmune disease post-vaccine. For the future vaccine, any precaution that can be given or an experience in that?
Yes, so that's a good question. We've got a talk on vaccines tomorrow that I might be covering a little bit about this. But there's two things I just want to quickly say about vaccination. If somebody has severe COVID, we want to protect them from reinfection because they may be vulnerable to having severe COVID again. So they need to be vaccinated. And your specific question is about vaccine-related adverse events. If somebody's had a complication with an mRNA vaccine, like a myocarditis, which is very rare but recognized, we would avoid an mRNA vaccine again. In terms of any other precautions that could be made, it depends on what the complication is and how severe it is in terms of delaying the vaccine dose or switching between the vaccines. The problem with the mRNA vaccines is that if somebody has a problem with an issue with an mRNA vaccine, there isn't a huge amount of choice in terms of what else to give them, depending on which part of the world you live in. So sometimes they may not be getting anything at all. And I've seen 2 myocarditis patients that were too fearful of having another vaccine. They had very mild myocarditis, it resolved, but they were fearful. And actually the physicians looking after them didn't want to either. So it's a very difficult situation, but fortunately, it's a difficult situation for a very small group of patients, which is some compensatory reassurance, but it's very, very difficult.
Thank you very much. We'll end this session and we'll go forward with the next final session. Thank you, Dr. Pooja. So our next session is a sponsored session by Janssen, and Professor Ahmed Abu Gamal is going to present. It gives me the honor to present him too.
Okay, Assalamu alaikum. Thanks, Jansen, for inviting me to present this talk. My talk will be about the new era in the management of psoriatic arthritis. Here is my disclosure. Psoriatic arthritis is well known as a type of inflammatory arthritis that's usually affecting patients with psoriasis. The percent of the development of psoriatic arthritis among psoriasis patients, almost about from 30 to 20% of them have the chance to develop a psoriatic arthritis based mainly on the extension of the psoriatic lesions and the presence of some special areas like the intergluteal areas and palmoplantar psoriasis and nail psoriasis. We're going to speak about the psoriatic arthritis as arthritis or rheumatic syndrome. We have a heterogeneity regarding the presentations. Usually it could come as a polyarthritis, symmetrical, small joints of the hands, looks like rheumatoid arthritis cases. And in other situation, you can see an oligoarthritis, asymmetrical, affecting mainly the lower limb as a pattern of spondyloarthropathy, plus the development of soft tissue inflammation of the whole digits, either in the toes or the fingers, plus the hallmark of the psoriatic or psoriatic arthritis, which is the interstitial inflammation commonly seen at the Achilles tendon insertion and the plantar fascia, to the other extreme of the psoriatic syndrome, which is the spondylitis or axial involvement. We can see a typical sacroiliitis and the axial involvement in psoriatic arthritis patients with the most severe form of arthritis mutilans. Away from the articular domains, we have an extra-articular domains, especially the development or high risk of comorbidity of obesity, depression, hypertension, cardiovascular involvements, and IBD, especially Crohn's, with the uveitis as a high prevalence of development in patients with psoriatic arthritis. So it's better we are calling it as psoriasis disease or psoriasis syndromes. So we have a different domains involvement with even without inside the musculoskeletal system, we have combinations of bone proliferations and erosion with soft tissue inflammations and activation of different types of cells, plus the involvement of the IBD and uveitis, skin and nails. With this huge number of targets, there is activation of different types of connective tissue cells ranging from osteoblasts, osteoclasts, the endothelial cells, and the keratinocytes. All of them are responsible for the release of the wide array of the inflammatory cytokines. Most of them are responsible for the development of these lesions in different combinations, as there is no one cytokine who could explain the development of one lesion in psoriatic arthritis. Coming to the root cause of inflammation or the main playing cells in psoriasis and psoriatic arthritis, which are dendritic cells in response to two different cytokines. We have activation and development of the T helper to T helper 17 and T helper 1 with the release of the most important and active inflammatory cytokines that produce most of the lesion in psoriatic arthritis. Coming from the actual lesions and cytokines, we have the potential targets so we can control the inflammation in psoriasis and psoriatic arthritis. And this actually target started almost 20 years back, to starting by the approval of anti-TNF in 2002 as the first biologic to be approved to control the inflammation in psoriatic arthritis, coming to the last and the most recent one approved in psoriatic arthritis management with interleukin 23. Interleukin 23 already is acting mainly to its corresponding receptor over to T helper 17, and through the interaction with the corresponding receptors, there is activation of inflammatory pathway and release of inflammatory cytokines. Neutralization of the interleukin 23 leaves the T helper 17 quiet with no activations, and this actually proved to be happened by the first one approved for the management of psoriatic arthritis, which is the gozalcomab, with the fully human monoclonal antibodies that target the interleukin 23 and prevent the interaction with the corresponding receptors. I will not go through details of the trial, just in 3 slides. The approval of gozalcomab or Tremfya gets the indication of psoriatic arthritis through 3 or 2 of them, the registration trial, and 1 trial regarding the TNF inhibitors from the Discover 1, Discover 2, and the Cosmos trial.
Discover-1 was mainly dedicated to show the efficacy of guselkumab in management psoriatic arthritis patients who failed to respond to conventional DMARDs and TNF inhibitors in 2 treatment arms, as the every 4 weeks and 8 weeks with the control arm up to week 24, with the primary endpoint to assess the ACR 20 at week 24. As we can notice here at week 24, the guselkumab shows superiority over the significant superiority over the placebo in achieving ACR 20, and this response actually maintained up to week 52 with continuous application of the post-treatment arm of guselkumab. Coming to Discover-2, which is mainly dedicated to assess the efficacy of guselkumab in patients who is naive to biologics, with the same design similar to Discover-1. And again, at week 24, we have a significant ACR 20 over placebo, and also maintains the response up to week 52 of continuous application of guselkumab. As regards the Cosmos trial, dedicated to patients who failed TNF inhibition in comparison to placebo, and again at week 24 we have a significant superiority at ACR 20 over the placebo arm. Coming to the clinical evidence among my patients, or the clinical application of the guselkumab in patients with psoriatic arthritis, I present 2 cases today. One of them is a female 52 years old with 15 years history of psoriasis involving her elbow, forearm, back, abdomen, and legs, was mainly on topical treatment on first presentation, and I saw her actually in September 2018. At that time, she presented with symmetrical arthritis affecting her hands, feet, with swelling and morning stiffness for the last 3 months before coming to my clinic, and her clinical assessment showing symmetrical arthritis involving the wrist and small joints of the hand, MCPs, BIPs, with bilateral enthesitis at the Achilles tendon, with dactylitis of the 4th right toe, with red scales showing active psoriatic skin lesions. For the comorbidities of this patient, which are already more prevalent in psoriatic arthritis and psoriasis in general, she has an obesity for BMI was 32, and diabetes mellitus, hypertension with depression, and the inflammatory marker was just positive, CRB is 5.7, ESR 12, and the ultrasound show a significant Doppler signal in the wrist was positive Doppler grade 2, and Achilles enthesitis with spare denoting chronicity, but with absent Bauer Doppler signal, and DAPSA score scored as 28 at that time. As we can see here, that we can notice this is the dorsal scan of the wrist joint. We can see from here, just the laser pointer here, we can see this is already the radius and the carpal. This is the radiocarpal joint recess. We can see an hypoechoic shadow distending the joint recess in the radiocarpal and the intercarpal recess. And this distension showing the Doppler signal inside, which is classified as grade 2 synovitis of the wrist joint. Coming to the Achilles tendon and dorsal scan of the posterior surface of the calcaneus, we can notice here hypoechogenicity of the Achilles tendon at insertion, with irregularity of the bone profile, with a significant step up cortical abnormalities of the bone cortex, denoting the presence of enthesophytes with distension and thickening at insertion, which is a sign of chronicity and chronic enthesitis of the Achilles tendon in psoriatic arthritis. Based on the guidelines, this patient already has no exposure before a conventional DMARDs. The Mr. Skit started in a weekly dose of injection 25 milligram plus NSAIDs with folic acid supplements and dipomidrol 1 shot to control the inflammation. After 3 months of the application, the tender joint count dropped, but not too much. We have tender joint count as 6, with swelling as 4, and Achilles tendinitis still significant. The dactylitis cleared, DAPSA decreased from 29 to 20 with partial skin response. In early 2009, almost in January, we start to put the patient on Cosentyx to control the inflammation and skin domain, plus continuation of methotrexate and NSAIDs to treat the patient pain. After 3 months, we have a significant reduction of the swelling and tender swelling joint count, with resolution of enthesitis in one side and significant drop of DAPSA to low disease activity blue 14, which is 13, and clear skin or PASI 100 after 3 months of application of secukinumab. Patient continue for 1 year in a good condition, but after 1 year, we start to have flaring of arthritis, increased up to 4 with the swelling joints as 3. Still, we have a significant left Achilles enthesitis. Dactylitis, it is not there, but DAPSA jumps up 14, which is already moderate disease activity, with also partial skin flare. There is already starting a secondary failure of secukinumab. Again, based on the recommendation, we can escalate up the dose of secukinumab to control the condition, and we increase the dose of Cosentyx to 300 milligrams with continuation of methotrexate and NSAIDs. And we got a significant, again, low disease activity. DAPSA went down to 12 with clear skin. Again, still we have the left Achilles enthesitis persistent. In late 2021, we get again another flare-up on the 300 with DAPSA again to 20 with a significant at that time skin flare with persistence of the Achilles enthesitis, and actually at that time was matching the approval of the Cosentyx or Tremfya in our country here. We start on switching to Tremfya at week 0, 4, and 12 with continuation of NSAIDs and methotrexate. And patient till now takes almost 3 doses, the 0, 4, and the 12 dose. The assessment showing only 1 tender and swollen count with clearance of enthesitis for the first time after 4 years of treatment. And still we have no dactylitis, and DAPSA went down to 8 after 3 doses of the Tremfya with completely clear skin. This actually was matching the data presented in the Discover-1, as we can see here, starts the efficacy as early as week 4 over the placebo. And in cases were, according to my patient here, after 12 weeks of applications, we have a significant superiority of the treatment over the placebo arm in the both treatment doses. Coming to the second case, it is male at times, 64 years old with long history of psoriasis, involving mainly his elbow, forearms, and legs, with diagnosis known already of psoriatic arthritis for 10 years before coming to my clinic. His history of treatment already started in methotrexate with partial response, and his treatment upgraded to adalimumab Humira for the last 5 years. And he has a comorbidity of hypertension, diabetes, hyperlipidemia, and he's already a significant smoker. This was on almost 2 months back. His clinical assessment showing as a severely tender and swelling bilateral knee arthritis with small joints affecting the wrist and the MCBs with a scale skin rash, but there is no enthesitis, no dactylitis, and normal nails, and his DAPSA score was 34. Very interesting, in his ultrasound scan of his knee, we can notice here a significant synovitis suprapatellar joint recess with synovial proliferation and distension with hypoechoic compressible signal of fluid. And in assessment of the posterior part of the knee, we have the coma-shaped Baker cyst communicating with the joint. And already we have this is a long axis showing the distortion of the line between the medial head of gastrocnemius and semimembranosus muscle with a typical moderate Baker cyst. Baker cyst present Baker cyst actually based on the data even with other arthritis and even osteoarthritis have a significant reduction of the functional ability of the patients, and this actually could have a significant role on the pain and already the DAPSA score of these patients. And the ultrasound scan of the suprapatellar scan of hyaline cartilage, we can see here a symmetrical narrowing of the medial compartment of the hyaline cartilage, indicating the presence of 2 at least abnormalities not related to psoriasis here. We have a Baker cyst and we have also an osteoarthritis of these patients. So for his inflammatory markers show a significant positive CRB and ACR. Uric acid, it's very important in this case, it is normal. Blood, the complete blood pressure is normal, and synovial fluid analysis, which is already also important to rule out any crystal arthropathies and inflammations or significant infection was already coming as negative. For this patient, I started with the Tremfya at week 0 and 4. He took only the loading dose and 1 dose after, with continuation of methotrexate with significant intra-articular steroid injection of both knees to control the inflammation and drainage of the Baker cyst under ultrasound. And after 1 month only of the treatment, we have a significant reduction of the tender joint count to 0 and swelling joint count to 1 with DAPSA down from 34 to 10 with clear skin. This patient already who failed conventional DMARDs and failed the anti-TNF before, which matching again the Cosmos trial, as we can see here, a significant superiority of the Tremfya arm over placebo at week 24 of treatment. That was my last slide, and finally, thank you. For any question. Okay, so
thank you,
question?
Professor Ahmad.
Yes.
I would like to know what's your experience in starting Tremfya in a naive patient before methotrexate?
Before methotrexate.
Yeah.
From my side as a rheumatologist, I don't have this opportunity. Actually, I hope I can do it. You know that we are already follow strict rules for approval of our patients based on the guidelines, and insurance are controlling all our medications. So we don't have any justifications for cases with psoriatic arthritis. We can go initially for Tremfya. I don't have this experience. In dermatology side, yes, he can already start based on the basis score. If it has over 11, he can start initially directly without starting with methotrexate. But actually, among my patients, I don't have this experience before.
Thank you.
It's only work on the peripheral arthritis, right? Not the axial, not the sacral.
Yes, among these two cases, it was already peripheral arthritis, not axial disease. But you know, based on the meta-analysis done by Philip Hillowell in last year, which representing the pooled analysis of data from Discover 1, Discover 2, they pooled some patients who already have a significant axial involvement, which already reassessed by radiological evidence of sacroiliitis before they starting the Tremfya, and they found a significant improvement in the assessment scores of modified ASIS and BUS-DI with removal subtraction of some factors that could be related to peripheral arthritis. So based on this, if the patient have already axial plus the other domains, it could have a benefit from starting Tremfya. But among these two patients, there's no axial involvement.
And should I add methotrexate with the Tremfya or only monotherapy?
Methotrexate for patients with
the peripheral arthritis.
It is, yes, for peripheral arthritis. Even for enthesitis now, we have a trial presented last year showing a significant or already a good response in NCCL part based on methotrexate. And actually in the coming version of the GRAPPA recommendations, there will be a rule for methotrexate in enthesitis even.
For patient with psoriatic arthritis who coming with axial involvement, usually those patients from the start with the biologics like Humira, for example, and the TNF. We saw several patients who improved their axial symptoms, but still skin manifestations. And you know, with psoriatic arthritis, we have no experience of adding other mechanism of action. Like, there is any research that patients who are on anti-TNF add on anti-interleukin-23 or other biologics to it?
Yes, there is some combination, but it's not still in the guidelines because, you know, combining biologic agents is already, most of them are off-label. They don't have medication for this. But there are some reports regarding especially the small molecules like apremilast or Otezla in combination to anti-TNF. There's a good reports regarding these domains. And also, I think presented today by Peter Nash, the combination of interleukin-23 and TNF inhibitors could be a valid options. But all of this is still already under research. So it could work or not. But combining methotrexate, it could help the skin plus the biological demand. Okay.
Can we develop immunogenicity over time to
For Trimfire?
yes,
Um,
or just lack of response like the other?
For immunogenicity, actually, as a fully human monoclonal antibody, the presence of immunogenicity is not reported. And still now, for all of my patients or others, the data showing it's for 52 weeks, as with continuation of resistance of the efficacy. So the effect of immunogenicity of this molecule, I think, is very low. I think there is some questions in the chat box. So we have, if the patient has axial elements from the start of, or develop axial manifestation later on while in treatment by Trimfire. So I think this answers this question, Ibrahim. If the patient have already an axial element from the start, if he is pure axial and axial is the main symptom, actually the answer is not interleukin-23 inhibition. But if he has axial plus the other domains, yes, this patient is valid to start with interleukin-23 inhibitors based on the pooled analysis Discover 1, Discover 2. And he's developed axial manifestation. While he is in treatment, you have to evaluate if the axial domain is the main symptomatizing part of the patient and is already the main limiting part and affecting the functional ability. You have to treat patient as axial. And the last recommendations that we have from the last update from the Euler axial, you have to go for interleukin-17 or TNF based on the skin involvement. Another question, why interleukin-23 inhibitors effective in axial PSA but not effective in axial SPA? Actually, this question, nobody on earth can answer this. Why exactly the cause? Because there is some theories about this. The enthesitis in the axial part is different than the enthesitis in the peripheral, and the types of the colonies of the T cells present on the peripheral enthesitis is different than the axial part. So it seems that the colonies of T cells on the axial enthesis are responding well to 17, but not responding to 23 inhibitors, while the peripheral enthesial parts is responding well to 23 inhibitors and 17. This is the last question here. A patient with PSA and failed methotrexate, control activity, what is to do? Actually, you have to classify the patients based on the domains according to the GRAVA. We have to go for the treatment paradigm for each domain involvement. This was last questions, and finally, thank you.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23p19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms, giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop.